Okay, well, we'll make a start. Good morning, everybody, and welcome. So, hope you've all had a good summer break and been out and about and enjoyed our great weather. First off, participants, we'd introduce when we reach the items, when you'd like to speak, put your hand up and let us know. We have got a long agenda, so just be mindful that on questioning, I'm happy for questions, but if it's already been said, then we don't need to necessarily repeat it, just agree with it. So I'll start off then. Apologies, please.
Thank you, Chairman. We've received apologies from Councillor Adams, Councillor Wright and Councillor Bokit. Thank you.
Brilliant, thank you. And I welcome those that are on live on Teams on the screen. So declarations of interest from members, if any. If you feel that any come about during the meeting, then just let us know. Go to minutes to confirm the minutes of the meeting on the 14th of July 2021 as a correct record. Can I have a proposer and a seconder, please? So I've got Councillor Clark and Councillor Key seconding. Thank you. All those in favour? Excellent, thank you. Any abstentions or against? No.
Sorry, Chairman. A question, if I may. I know it's done and past it, but on the minutes we were informed that 72 people had responded to inquiries from the council, reference the flat rate problem that we had. Could we at a later stage be informed how much further we've got with the client response, and if we're anywhere nearer getting to everybody on that rather long list? Thank you.
Yeah, okay. Do you want to pick that up, Simon, and just send that round via email? That's good. Brilliant. Thank you. Okay. So, hello.
Thank you. I'd like to second that. I was very, very disturbed by what we saw at the last scrutiny committee about the flat rate charge, and I'd like to second that, and I'd like that update. Does that mean, if it's going to be by email, is that going to be today?
Excuse me, Chair, would you like me to give 5 minutes?
Yes.
Yes, that would be really helpful. Thank you very much.
The button's not working. Oh, okay, thank you. We did go to executive yesterday with the update. We're on target to have distributed all the letters by the end of October. We have 484 families that we're working with at the moment. 199 of those families have actually responded and been issued with refunds. Obviously, we have to work with them to give them the money because we don't hold the details, etc., etc. So we've got 407 that are we're waiting for the letters to go out, waiting for their addresses to come back from them. But so far, 199 out of the 484 have gone, and we will have gone through the full 1,500 by 31st of October, as the paper identified in the last meeting.
I'm sorry, I don't want to hijack this, but can I ask if we can have that by email in writing, please?
Absolutely.
And can we be told how much of the total amount of money that's outstanding is and how much of it will have been paid back, so we can sort of see where we are and see how many people who were overcharged have basically got their justice? Thank you.
Yes, the total debt, if everybody comes back for the refunds, it's £384,000. We've distributed £67,000 of that at the moment. So the difference will be what we'll be distributing between now and the end of October, as long as the families want to work with us and want that money back. But I can put that in email in however I would do that, yes. No problem.
Thanks very much.
Okay.
Forget, it's when you're there, you're all right, it's automatic. Announcements, none from myself. I see Liz Sneath, welcome back, Liz. And if there's anything, we've got apologies from Wendy. So Liz is here on Wendy's behalf, so welcome. Sue Woolley or Colin Matthews? I don't think. There's no comment. So, Glenn, is there anything?
I'm here, but no comment.
So, thank you. And Glenn, anything?
Thank you, Chair. Nothing from me. Thank you, other than to say, I suppose, on reflection, the comments that the PM made in the House of Commons yesterday at lunchtime related to future funding and social care reform. Colleagues and I will be working on the detail of what that might mean for Lincolnshire over the coming months. Further detail to follow. Thank you.
Thank you. We will be receiving a paper at some point going forward on the impact of what was said yesterday and in effect the sort of potential financial impact as well to for those that are on that will be means tested. Potentially there will be a lot more means testing happen, so that will be one area, and then of course the how much it is to support them, but a paper will come back when once it's passed through Parliament and further details are revealed. So, Councillor Clark.
Sorry, Chairman. I'm a little bit hard of hearing. I wonder whether we could tweak the sound volume a little, please, so I can hear, particularly when the information's coming from the screen. I had difficulty catching all of that. Thank you.
Yes, no, I'm a bit struggle as well on hearing at times. So if you can crank the volume up, we're all right, please. Councillor Young.
Thank you, Chairman. Just on that announcement, it'd be useful to know whether yesterday's announcement is a sticking plaster for a short-term solution or a long-term fix, because I think it is more than likely the short-term fix rather than solution rather than the long-term fix. But I think that's a real big issue for us as a scrutiny committee, and I think we need to understand that, really. Thank you, Chairman.
Thank you. As I said, it is coming back. We will bring a paper back once it's passed through Parliament and we get the more, what I call attention to detail. But what we can say is whether it's short-term or long-term, whatever your opinions are, there's one thing that is really positive, is it is being finally put on the agenda and somebody has actually started to deal with the case that really is been long overdue and people have avoided over the last period of time. Karen, and then we'll move on.
Thanks. I'd just like to make the comment because my mum's going through this at the moment. She went into a care home about a month ago, and any savings over 23,000, which she has to totally fund her own care, and it's only gone down to 20,000, so it's actually not very different at all. And as well as that, as a pretty modestly paid nurse, it's going to hit me the hike in national insurance contributions and all of those care workers as well. I was at her care home on the bank holiday, and the staff in there were being paid just ordinary flat rate. They don't even get a bonus like we do on the NHS, and this is going to hit them and hit them hard. So I want no pretense that this is any kind of a wonderful solution. I'm sorry, I can't sit and listen to it. Thank you.
Thank you, and I'm sure, as we're all aware, that it will be fine-tuned as well as it's developed, so full impact will be revealed as we go forward. Okay, while I'm also on, I'd like to welcome Lucy Gavin here, who's a consultant to public health, so welcome and enjoy your observation of how scrutiny works at Lincolnshire County Council. And on that note, we will have an overview of prevention services involving public health, led by our very own Derek Ward. And I think David Postle's on the, is he live somewhere as well? Is he in or not? Service Manager for the Wellbeing?
I am. Thank you, Chair.
On there. Okay, brilliant. Right, well, Derek, if you'd like to start item 5, please.
Yep, thank you, Councillor Marfleet. Do we want to put the presentation up? With apologies for people who've seen this before, but I'm conscious that a number of members of scrutiny might be new to this area, so the Chair thought it would be a good idea to run through the areas that I cover, and broadly speaking, two core areas. The second presentation I'm going to cover is the statutory responsibilities of the Director of Public Health, and this first one is actually the wider responsibilities that I discharge on behalf of the Council around prevention and early intervention, above and beyond what normally a Director of Public Health would be required to do. Really important before we go any further, just to try to set the context, to talk about prevention. Most people think prevention is about things like telling people not to smoke, telling people not to drink, telling people not to eat fatty foods, telling people not to do all the things that they like doing. And as we all know, especially if you've got teenage children like me, telling them what not to do is not the best way to go about it. Trying to help people make healthier choices and change their behaviours is absolutely fundamental to what we need to do. Not least, given the previous conversation about funding in the NHS and social care, if we keep dealing with the problems once they manifest themselves and don't stop them happening, we will always have too little money to deal with the problems. So we do need to focus on trying to help people avoid ill health. And that really is what primary prevention is about. But how we do it is far more sophisticated than me wagging a finger at people and telling them not to do naughty things. And we'll come on to that in a minute. Public health and what we need to do as a council and as an NHS and social care system is not just about stopping people getting ill in the first place. It is also about trying to identify people very early on in the early stages of illness, which is where we move from what we call primary prevention into secondary prevention, helping people who have had a cardiovascular event, a stroke or a heart attack, maybe had a fall, helping them to make sure that doesn't happen again, because that's going to be absolutely fundamental. So people who are healthy, stop them getting ill. People who've maybe had one illness, one particular event, trying to help them to make sure that they change their behaviours, they get the support, maybe the housing adaptations that are required so that they don't have another fall. And that's secondary prevention. There are also areas like diabetes where we can identify people who are at very high risk of diabetes, and with a very intensive package of lifestyle change, basically diet, nutrition, as the chair was talking to me about before, we can reverse the likelihood of them going on to get diabetes. That's another example of secondary prevention. And then tertiary prevention is about trying to help people who do have existing conditions, existing diseases. In Lincolnshire, a lot of those people are older adults. A lot of those people don't have just one condition. They might have 2, 3, 4, 5 different conditions. Tertiary prevention is about basically trying to help them live the best life they can, given the conditions they've got, trying to make sure that those conditions don't deteriorate. And an example of that might be rehabilitation for people who've maybe gone into a hospital and then go into a step-down facility from a care home. Getting them back in their own homes is really, really important. But also people who have, for example, diabetes, making sure that we are screening properly so that we avoid complications of diabetes as well. So these are all different aspects of prevention. A lot of people, when they hear public health, they just think about the primary prevention stuff. We spend at least as much of our time in the secondary prevention and tertiary prevention spaces, because that's where a lot of money can be saved, and therefore much better outcomes for the people of Lincolnshire can be achieved. Chair, I'm happy to take questions as we go if that would be helpful, or do it at the end. I'll be guided by you and the committee. I won't go through this in a lot of detail. These are just some of the key themes, the principles that we work to as a public health division whenever we are looking at bringing forwards a new programme of work. Very much we need to do it with the people who we're trying to help. Often the areas that we look at are because we've been told it's an area that we need to look at by the people of Lincolnshire, either through yourselves or through some of our contacts and our groups. Public health is often straddles health, social care, so the NHS, social care and the council. A lot of the work that we do and we are trained to do is to help with redesigning pathways. And because we are trained to do that, but we aren't coming from a particular clinical specialty, then often clinicians will ask us to help with that redesign. So an example would be musculoskeletal conditions. We need to look at how we help people with bad backs, bad necks. It's one of the big areas of the burden of disease in Lincolnshire, which we'll come on to in a minute. If we want to redesign that pathway, but that was led by a physiotherapist, even if the outcome was the right outcome in terms of the evidence base, there's the risk that, I don't know, a secondary care orthopaedic surgeon's going to say, yes, well, you say more physiotherapy because you're a physiotherapist. And equally, if actually what we need is more secondary care orthopaedic surgery, then that could be challenged. Public health practitioners often lead those sort of reviews because we try to make sure we are evidence-based and we are coming at it with a clean slate to try to come up with the right outcome for the people of Lincolnshire. Next slide, please. I'll just put this on. Happy to come back to scrutiny in the future as this develops. One of the areas that we're particularly strong in Lincolnshire is intelligence and knowledge, and anybody who's been keeping up to, I'm sure you've all been keeping up to date with COVID data. We've pulled together an awful lot of intelligence and data in the county around COVID, and we've got a really strong and robust public health intelligence team that sits part of my division. We need to go further than just dealing with COVID. We need to really understand how people experience health and social care right the way across the pathway. At the moment, somebody goes into hospital, we know why they've gone in, we know what's happened to them in hospital, and we know when they've been discharged. But what we don't know is how many times they went to the GP before they went into hospital with a condition that might be related to why they went into hospital. The GP knows that, but the system doesn't know that. We know as a council all of the social care and other input that we give to that individual, but that's not connected up to GP information. It's not connected up to hospital information. What we've got to do is bring all of those data together, start to understand it better, turn it from data into intelligence, and then change how we do things across the pathway, not just in the hospital, not just in primary care, not just in the mental health trust or in a community psychiatric nurses delivery out in the community. We've got to do it in the whole. Musculoskeletal conditions is another good example of that. There's lots of different aspects we would need to change. In a nutshell, population health management is something that all systems, integrated care systems, ICSs, are being asked to take forwards, and it's about trying to connect those data up to understand better how people experience health and social care in the place that they're in.
Thanks. First of all, thanks for the valuable work you do. It really is valuable. I wanted to ask the question. You've talked a lot about physical health. Are you looking at the mental health aspect? And if you are doing it, could you just tell me what you're doing so that I know, please? It's not a catch question. Thank you.
Yes, absolutely. No health without mental health, as we know, and we need that parity of esteem. We are doing a lot of work around mental health. It tends to be components of other programs that we're doing, and I'll come on to it a little bit later on in the presentation. Once we go through that, actually Lucy's going to be leading our work around mental health and wellbeing, along with our new Chief Executive of our Mental Health Trust, Sarah. So we've been speaking to her, and once that's developed a bit further, happy to come back to scrutiny with a targeted presentation on that.
Hi, yeah, just very briefly, because I know you said you wanted us to note this, but can I just ask you, you're talking about all of that data and bringing it all together and it's all got to link up. I spotted that as well and thought, how are you going to do that? Can you just tell me, probably how long is a piece of string, but how long do you think that's going to take, you know, to have any real effect so that we can actually scrutinise that for you?
Yes, thanks, Councillor Clark. We are starting a pilot programme of work next month. We were looking for early outcomes of that by the end of this calendar year, in particular pathways, and then we'll build on that over the coming year. So probably early 22, we can come back with the findings of that work and describe what we've done and what we're starting to see. The plan is that through 22 and into 23, as the integrated care system develops and becomes a statutory entity, the legislation's going through Parliament at the moment, we will have this as a fundamental plank of everything that we do across health, social care and public health.
Thank you, Chairman. Wonderful that we're pursuing the prevention angle. I think that's the way forward for a lot of things, but particularly in health. Have you got a strategy to put this information out to the public? You know, newspapers, yes, radio slots maybe, where you could get an ideal 20-minute programme every week, every month to push it with the help of them, or are we going to use more social media in order to target the younger element of the public who use a phone more than they use any other form of media? And similarly, on your chart that you've put together on page 21, are you going to be circulating that to all the partners? So again, you know, all working off the same song sheet to get a better result. Thank you.
Thanks, Councillor Clark. Short answer is yes to all of that. We've already circulated a lot of those charts that are in this presentation to our partners, and I'll come on to that when I get to those slides, if that's okay. In terms of the communications, it's a horses for courses sort of argument. I've never been doing so much comms and media as I have with COVID, because obviously everybody wants to be updated. So whether that's the Lincolnite or other online papers, media, whether that's radio, for quite a long time we were on the breakfast show on BBC Lincolnshire every morning. Either myself or Andy were covering there, and we do TV and things like that quite a lot. The real trick here is trying to broaden out those comms messages, so it's not just about COVID, it's about some of the good stuff that people can do to look after themselves and how we help them. In terms of how we communicate, the last person you want to ask about that is me. That's why we've got a comms team who are expert in this sort of stuff. I'm really comfortable doing those sort of broadcast media, but as you said, you know, teenagers aren't going to be watching Peter Levy on of an evening, much to his disgust, I'm sure. So what we are looking to do is more video clips using TikTok, YouTube, those sort of devices. We've got actually a video, but we won't probably have time to show it today. I want to work with our comms team to pull together more short clips that we can use in a different way, because if we just keep sending, you know, council papers out to, then nobody's going to, well, not nobody's going to read them, but a certain section of the population is going to read it. We need video, we need, TikTok and lots of different Periscope. There's loads of different ways that we can communicate, but it has to be visual, it has to be infographics and videos. So we've definitely got that in the plan. We've just got to work that through.
Councillor Key.
Yes, thank you. Derek, could I just say I've listened to and watched a lot of your presentations, and I think I can speak for many people that they've found them very useful, very clear, concise. We knew exactly what to do and what the message you were getting across. I think you've done a great job. Thank you very much.
Thank you. Right, shall we crack on? This is just trying to show, tie together a little bit of what I've just talked about in terms of primary, secondary and tertiary prevention. And that inverted pyramid is, we need to hit the vast majority of people with primary prevention, and as we come down, there's less people in secondary prevention because they're people who are at risk of diseases or have got the early stages, and then tertiary is a smaller group again. Having said that, when you look at the impact, helping somebody who's got end-stage emphysema live the best life that they can is obviously massively important to that person. It's a small group of people in tertiary prevention, but it's really important. Helping people to lose 5% of their body weight, which is what the CMO would recommend. There's an awful lot of people, probably 7 out of 10 people in Lincolnshire are overweight or obese. So it's a small amount of weight, but if we can target a lot of people, that actually adds up to an awful lot of benefit, and we'll come on to that in a moment. All of that is focused on addressing health inequalities. So we do target particular communities particular age bands, particular groups, depending on what we're looking at, because health inequalities is complex. And that's a whole different presentation I'm happy to do another time if people would be interested in. The right-hand side is, great, okay, so that's what you want to do, what you're doing about it. The right-hand side lists some of those, and as Councillor Clark just said, media messaging is really, really key to this. We do a lot of work with our own employee health and wellbeing, because our staff are our primary resource. So whatever we can do to make sure our staff are fit and healthy as a county council is absolutely vital, and we've got a whole programme around that. Then coming down, some of the secondary prevention work that we do. One Year Lincolnshire will come on to, sexual health services and other things we'll come on to in the Director of Public Health bit in a minute, and the wellbeing service we've got somebody else to speak to. And then tertiary, we've got things like integrated community equipment services. That's some of the adaptations we do to people's homes to allow them to live in their own homes longer, for as long as possible. We've got a telecare offer. All the work we've been doing around COVID generally is tertiary. It's about, for people who've caught COVID, how do we support them and how do we stop them passing it on? But there is some primary and secondary prevention there. And then we have a statutory responsibility as a council to provide advice and support into the NHS. And that's also mostly focused about how we get the NHS to improve what they're doing so that people in Lincolnshire get better outcomes. Next slide, thanks. I'm going to whiz through these because I'm conscious that it's a long agenda and we've got a lot. Happy to pick any of these up at a later date. In terms of some of the primary prevention work, Connect to Support is a website that we fund that is all about trying to connect communities up with voluntary and third sector organisations. I'd suggest the best thing to do, just go on and have a play. If you don't know about it, Connect to Support, Lincolnshire, just go onto the website. Different organisations can put their own information on there, and then communities, individuals can go in and have a look and connect up. If somebody wants to take part in a walk-in programme, then that will be on there. There might be, well, there's a whole range of stuff, not even worth trying to go through, but it also has a lot of our provider information for our care home side as well. So that's one example. We have a statutory responsibility to commission and ensure that we have an NHS health check programme, which is around trying to pick people up who are at risk of more severe disease early. We do that across the county. The programme is aimed at everybody over 40 but below 75, and you should get invited once every 5 years, unless you're already known to your GP because you might have hypertension or something else, in which case the GP should be checking on you anyway, so you're outside of this programme. But it's very much about trying to catch people early, provide them with advice and support and intervention so that they don't go on to have a stroke or a heart attack or develop some of the cancers. One U Lincolnshire is our integrated lifestyle service. This is something that we've put in place over the past 3 years, and this is really about primary and secondary prevention. Again, go onto the website. The video that we'll send around, I think, is the One U Links video as well. Yeah, it is. And for the general population, anybody in Lincolnshire can go onto their website and get advice and support about how to improve their physical activity, change their diet so that they'll lose weight. If people are maybe drinking a bit more than they want to from an alcohol perspective, they can get advice and support. But also social care experts, public health people, NHS workers can all refer people into One U Lincolnshire if they meet the criteria, at which point they will get one-to-one or group dedicated support and packages, all evidence-based, to help them change their behaviour. It's about losing weight, it's about changing low to medium levels of alcohol consumption that might be a concern. If it's a high level alcohol or substance misuse issue, then we have a different service for that. And anybody who smokes, who wants to quit, One U Lincolnshire is there to help you do that. Provide nicotine replacement therapies, all of the different pharmacological interventions that we've got, along with behaviour change, motivational interviewing based support to really help people quit if they want to quit. So anybody who's a smoker and wants to quit, please go and have a look at 1U Lincolnshire. Please let all of your constituents know 1U Lincolnshire is there for them. The single worst thing you can do to yourself legally is smoke. So if you want to quit, we are here to help you quit. Just some achievements, you'll have seen those in the slide pack, so I won't go through, but interesting that even during COVID, this is around the COVID, 2,200 people in Lincolnshire were supported through 1U Lincolnshire to quit smoking. And you'll see there, people in the service, nearly 2,000 people, lost the equivalent of 4 hippopotamuses or hippopotami, I don't know, worth of weight over that period of time. We do know COVID will have had a significant impact on people. We don't exactly know what that will look like and how that will be distributed across the county. We know it's going to make, and it has made, health inequalities worse. So we've got to pay close attention to that. And then we've got that video. We'll send round separately, given the time. Wellbeing service. I think I get to pass over on that one. You dial in.
Is that my cue to
That's your cue, yeah.
Sorry, sorry. I got the papers, but I wasn't sure exactly what I needed to provide for the meeting. So I'm happy to take questions about wellbeing from councillors and anybody attending. But if it's okay with everybody, I can just give you a short overview of. Turn my camera on. Give you a short overview of what the service does, and I'll apologise for any background noise. We've actually had to mobilise very quickly, and I'm in Grantham at the moment, so not in my normal place of work. So please feel free, councillors, to give a shout about any questions that you've got. But for those that aren't aware, Wellbeing Service is now in its 4th year, and we went live in 2018. And we do provide prevention services for people in Lincolnshire, and it's equitable right across the county. And we are a partnership, and this was something that was quite novel. We are a partnership of the district councils providing the service. So to give you a quick idea of what it is, and I'm conscious of time, so I won't go into too much detail, but we provide a number of services, including a holistic and person-centred assessment of need with individuals, which then creates a support plan, and we look at how we can actually help people live that better life and prevent them from escalating to require paid for adult social care services or the NHS. And some of the more practical ways that we do that is we can provide people with the small aids for daily living and minor adaptations, and we can do that quickly and professionally. And whereas some of the services that are available out there, the equipment is loaned to people through the ISIS contract or through the NHS, we actually assist the people to purchase the equipment, and that can be from us or it can be from reputable suppliers, and we can assist them to sort that out. But we install the equipment for them free of charge, and that is across the county. And we work to a fairly tight timescale on that. So from the person saying they would like some equipment, we work to a 7-day timescale on that. And if finances are somewhat of a challenge for people, we can allow them to pay for the equipment over a longer period of time, similar to how they would for the council tax. And that's a benefit of us being the district council. And minor adaptations, the majority of the work we do on that is grab rails strategically placed in and around someone's home, or as it's referred to, a mop rail. So that's an extra handrail going up the stairs. It just helps people to continue to be able to mobilise around the house and around the outside of their house, reducing the risk of falls, which I'm sure we all know is a big cause of hospital admissions in the age group that we mainly deal with. We also provide, linked in with the customer's own telecare service, we provide a service where we can be the emergency contact. So if the person has family members that can normally respond to them but can't guarantee, or let's say they've moved to the area years ago and they don't have any direct family or friends that can act as that emergency contact, we have a team of people that are actually deployed in fire stations strategically located around the county, and we aim to, once the person activates the telecare system, once we're advised that we need to deploy, we aim to be with that person within 45 minutes. And that is very quick compared to, say, ambulance service, who would consider these calls to be a lower priority. But because somebody, if they have fallen and are able to remobilise and get moving again, if they have to wait several or over 45 minutes, maybe a couple of hours for an ambulance to turn up to assist them, then they may have to then be conveyed to hospital. So we aim to get there within 45 minutes. And the last data that I had for August showed that around 93% of the call-outs that we attended in that month were reached within the 45 minutes, and almost 100% were attended within an hour. And considering the size of the county, that shows the effectiveness of the team in doing that. In addition to these services, we also work directly with the hospitals to identify patients who may be delayed from leaving hospital because they've got a housing or wellbeing related need, and we work directly with that customer to try and navigate around those. So when the person is medically fit for discharge from hospital, or if, say, they're going to be admitted through A&E or in the emergency departments, if something isn't sorted for them, we work directly with them to either prevent them being admitted or to assist in that discharge. And that is a dedicated team that we've got there. The bulk of the work that we do directly with the customer is identifying the needs, and that can be lifestyle needs. You know, they've had significant change in circumstance, which is often due to bereavement or something like that. We help them with finances, we help them with engaging with the local communities. And like I say, we have an assessment process that identifies that. And then we have a team of support workers that will go in and work with that customer for up to 12 weeks to help them, to empower them to meet those needs. And we use a scoring system when we start engaging with the customer, and we ask the customer to score themselves on the needs that they've identified as they enter the service. And that is on a scale that looks at whether or not they feel able to cope with that situation or not. And then we ask them to score themselves when they leave. And around 98% of people that come through the service will confirm that they feel better in the scoring once they exit the service than when they started. So they feel more able to resolve these issues or to manage these issues going forward once they exit the service. As part of that process, we also asked them, we wanted to get an idea of how much of an improvement, how much better do they feel about their situation. And the percentage increase that we monitor shows that it's over 300% in the scoring that they feel better. So that just shows for us how well the customers, once they exit the service, feel about the situation they're in. Now, I won't go into any more detail, but if councillors do have any questions about the service, about how we've approached or assisted in COVID or any of the other work, please feel free to give me a shout.
Thanks. My first question was about the teleservice, because my mum used to have, she had Age UK carers, and we had a thing where she had something around her neck when she fell, and I have to say it was absolutely marvellous. It was great, but that cost, I think it was about 25 quid a month. Is that one and the same thing as we've just heard about? Because my only concern would be that my mum could afford 25 quid a month and not everybody can. And my second question was about waiting lists for the OT service. First of all, in a non-hospital setting, because we know that everything's hurried up when people are in hospital because we need the beds. But when you're in your own home, if you need to see an OT for any of these things like grab rails and that, first of all, is there a wait for the OT service? And if there is a wait, and I think I know the answer to this one, how long is that wait? And secondly, if you're then identified as needing things like grab rails or a higher Lucy or something, is there a wait to get those things? And if there is, how long is that wait? Thank you.
Thanks, Councillor. Really good questions. And on the first question, the response service that links in with the telecare, there is a cost to it, but it is heavily subsidised by yourselves through the contract. And the charge to the customer directly is just £2.50 a week, and that is locked in. That will not go up throughout the initial term of our contract. The service costs more than that to provide, but like I say, it is subsidised through the contract. But we will also work with customers if they are struggling financially. We'll work directly with them to try and address that. And we don't take the stance that if somebody is genuinely struggling to pay for things, we don't take enforcement action with regards to recovering these monies. For ourselves, we prefer to make sure that the most vulnerable do have the service. But of course, we have a contract to maintain, and the income that is generated from these charges does go straight back into providing the service. And your second question, the equipment that we supply actually sits prior to somebody needing a full OT assessment. So when we go in, we will work with the customer, and it's normally the customer that tells us what it is they're wanting, or we might suggest to them that certain things may help their situation, but we don't prescribe the equipment. We work with the customer, we empower the customer to begin to address their own needs. And again, we work to a 7-day turnaround. So once the customer says to us, yes, can I have this grab rail, or can I have this mop rail, so the extra handrail up the stairs, we work to get that in for them within the 7 days. If the customer does have what we feel are more in-depth needs, and we feel an OT assessment is required, then we work directly with the OT team to refer them in. And you rightly said the OT team are often under a lot of pressure with regards to getting out to do the full assessments, but we would work with them. And if we can get something put in temporarily, we will do. So it doesn't necessarily have to wait for the OT.
Can I just ask, though, is there a waiting time if someone feels they need to see an OT? And it's not a criticism of you, I'm just trying to identify if you're under-resourced and understaffed.
Could I just jump in there? Because I think we a little bit of a distinction between what the Wellbeing Service provide. We've then got wider telecare and community equipment services, which we'll come on to a little bit, but we could always come back because we are in the process of starting to recommission both of those. And then in terms of the OT, I'm going to pass over to Ros as the expert on that one, because she'll be able to give you the detail.
And just to be clear, we are here for an overview of the preventative service rather than getting into the nitty-gritty of questions like how long and what time, or else we'll be here all day.
We are here to scrutinise, though, with respect.
We are here to scrutinise, but actually this is about an information item at this point in time to get a better understanding of the preventative services and public health.
Okay, we will be bringing a presentation of... We will be bringing a presentation of the OT service in December, so we will be bringing some facts and figures then. There is a waiting list. There has been a transformation of OT over the last 2 years. Those waiting lists have come down significantly, particularly the very long ones of 100 days. There isn't any actual benchmarking in England, so there's no national benchmarking about performance indicators, but from what we understand, we are high performing. We're working incredibly hard to get waiting lists down, and what we have put in place is that there is an initial conversation with the person to look at if there's anything that we can put in immediately, and that way is been very supportive. As people will know, there is a national issue about OTs. They are very difficult to recruit to, and again, we're looking at innovative ways of managing that as well.
Thank you. Councillor Mike Clark.
Thank you, Chairman. Could I ask the gentleman, firstly, I think the Wellbeing Service is operating well and providing a good service. Are you able to tell us how many people you reach over a 12-month period?
Yes, Councillor. Of course, last year when we were in COVID, the numbers were slightly skewed for the main service. But we deal with around 7,000 people every year coming through the main service, at the end of of the COVID year, we had actually dealt with 6,500 people for the main service, but the team had also dealt with 6,500 people providing the COVID support. So it is a very busy service. But we're set up in a way that we can respond quickly to those enquiries.
Can I just add to that, if I may, that Wellbeing Services produced a really good annual report. It's quite visual, got lots of numbers and data in there, so we could include that in the minutes, the link to the Wellbeing Service annual report, and lots of facts and figures and detail in there for members as well. Great, thanks. So shall we just carry on? I'll find my slides. So yeah, the slides that we have just outline the Wellbeing Service. So I'll jump through those because I think we've covered those really well. And then moving on to the next one, which is the Community Equipment Service. There are some aspects of this that's delivered through the Wellbeing Service, as we've just heard about. There's a wider Community Equipment Service programme that we are just in the beginning of looking at to recommission as well. So I won't go into the detail. There are some facts and figures there. Really comfortable, really happy. If anybody wants to get in touch afterwards for more detail, we can provide that at any point. So next slide, please. And that's just gives you an overview of the other parts of the Community Equipment Service. But we pretty well cover that. Councillor.
Yeah, sorry to go back. The equipment supply service, one of the big things I get is, and I did quickly see the figures flash up, the equipment collected for reuse.
Yes.
It's because I think a lot of people in Lincolnshire have probably got some in the garage.
Yeah.
I did see on the news some time ago, there's another area, I think it was probably Yorkshire, North Lincolnshire, around there, were having days when people could just take them and deliver them, and they were getting masses of stuff brought back. Has that been thought of for us?
I don't know about an amnesty day as such. I'm looking at Pam here because we are in the process of looking at that. One of the key areas is to make sure we get equipment back from people. When
I can tell you, there's loads of it about, and with us wanting to recycle everything anyway from a climate point of view.
Absolutely.
But also the economic point of view, I think it would be good to have, it's a good name actually, an amnesty day, and I think you'd be surprised how much we get back.
We'll certainly look at that, yeah.
Actually, just on that, I mean, you are right. It's there is a lot of equipment out there that is sort of left, and I suppose a lot of it is by the time somebody goes and picks it up, the cost actually becomes quite expensive. However, what might be worth doing is there is no reason why somebody couldn't take it to the local recycle centres and actually it all be there and collected in one swoop. And actually, I would suggest that we pass that over to our recycling committee to look at, say, having a collection point for all the products.
Yeah, I think I absolutely agree, and we are doing as a paper going to the DLT for a proof of concept to look at just that, but that's a short-term option. What we need is a different model within the service currently provided that actually targets that equipment that's out in the community day in, day out, that brings the equipment back in. because every time we leave it out in the community, we Lincolnshire leave it out in the community, we're buying new to then give out to the next person. Actually, our financial model would show that we could continue to support the increase in demand through a better recycling rate. So our contract is due for reprocurement in 2023, and the project board has agreed that the new financial model is the way to go. So over the coming months, DLT will receive a paper on that, and that will address both the short-term amnesty, if that's what we want to title it, but also a longer-term sustainable model that brings that equipment back in.
If I could just add, I just know there's loads out there and people don't know what to do with it. And often they said they don't know where to go, and people say, oh, we don't want it, and it ends up just getting shoved in the garage. And I think we'll be amazed how much comes in just in one day. Thank you.
Yeah, really good point. And I think the short term, over the next 6-12 months, absolutely, we'll look at it through the programme board, but then it's built into the new commissioning model. But if we can get some of the equipment back and reuse it, then obviously we're making our money go further, which means we can provide broader services to more people. Which
yes,
is
thank you. Sorry to have interrupted, but I just know that's a big thing. Thank you.
Thank you.
I mean, just on that, then, if the short term is the issue, can we look at using the recycle centre as a drop-off point?
Yeah, yes, we'll perform it as part of the DLT conversation, which I think is due in October. So it's part of that. We'll bring it as part of that paper, and then it'll come back through here, depending on the outcome from DLT.
Yeah, I'll make sure that's picked up through my team and Pam as we build that short term.
I mean, you can drop all your stuff off for a charity, and there's clothes and all that sort of stuff there. It's not just a case of all dump everything, but
absolutely.
Brilliant. Right, we'll carry on.
Yeah, and apologies, there is a lot here on purpose to try to give scrutiny a real understanding of the breadth of what we do around the preventative agenda before we even get into my day job, if you like. So apologies, there's a lot here, but I think it's really important to pick out some of these areas that you might want to look at in more detail over the life of scrutiny as well. One of the other areas I discharge on behalf of adult care community wellbeing, although it links into the wider parts of the council, is digital. So we were talking about more videos to communicate, for example, but also we use quite high-tech kit as well. And again, Ros may want to jump in on some of this, but we are helping our care homes to remote monitor blood pressure, temperature, blood oxygen levels for people, so that we don't have to take nurses from other duties and bring them into a care home. We can do all of that remotely, and that's what Wisan and the Blue Box does. We now have, I think, all of our care homes on NHS net, so they can send clinical information securely between themselves and their general practice or hospital providers, which wasn't the case. And we're also doing some pilots on further developing remote monitoring for people in their own homes, not just in care homes. All of this will have a benefit to our social workers and our staff, because we're a big old county. It takes a long time to get around. And if really what we just need to know is somebody's temperature, and we can do that remotely, then that's going to obviously save a lot of time and effort for everybody involved. But also it's a real benefit to our NHS colleagues. And as we move towards a more integrated health and social care system, this area is going to develop a lot. We've also got House, which is slightly different. And what that is a package of, there's a smart plug, there's a sensor that goes on the door, there's a motion sensor that goes in a room. And what that does is, if somebody is maybe at risk of falling or has dementia but is living in their own home, it monitors what that person normally does over maybe a 2-3 week period. When would they put the kettle on? Because we'll put the smart plug on there to monitor it. When would they normally get up? And you'd pick them up on the motion sensor as they go along their hallway. When would they go out or not go out? And if the pattern on any given day is a normal pattern, then fine. If the pattern looks different, if the kettle didn't go on, if the doors opened at 3 o'clock in the morning, then House will alert their loved ones. It might be a family member, it might be a carer, and say something's going on, you might want to check in. So it's a remote monitoring. It doesn't intervene. It's passive. Obviously, it's done with complete consent. So the individual and their family have to want it. But we are piloting it. And what we're finding is, as much as the physical benefits for the person, it provides enormous comfort for the carers, because they know that if their mum or their dad maybe is struggling and hasn't got out of bed, then they'll get an alert and then they can go. And it provides peace of mind. And we were talking about mental health and well-being, and this is one of those areas I think that could well develop. There's a question obviously about how much this can be provided for and how much people might want to buy it themselves or buy it for their family and put it in. But that's why we're having a pilot and we're looking at proof of concept with this. So just a couple of examples. There's a whole range. We have a digital roadmap in adult care community wellbeing. It's one of the areas I think we are absolutely at the top of the shop on in terms of trying new things to help the people of Lincolnshire. Partly that's because we've got a really good team in this area, and obviously it's been a priority for Glenn and the Directorate for a number of years. And also we are a big, diverse, spread out rural county with coastal communities, so we need ways to deliver services differently.
Just on remote monitoring, there are loads of gadgets out there on the internet that you can actually buy and you can actually put in your house, because we've used them, and they basically monitor the movements throughout wherever you've got it set, and actually it pings your phone, doesn't matter where you are, says what actually is going on, and actually you can even get an image of where they've moved to and everything else. So I think from this is what we provide, but there's also a huge range of modern equipment for benefits.
Absolutely, and there's a whole range of equipment, some of which we may want to specify and either supply or suggest people buy and install. Others might just be very low-level support that people might want to put in for their loved ones. And one of the pieces of work that we're doing with all of our staff is to get them to understand the range of options available and talk through those options with people, whether it's through the Wellbeing Service, whether it's through our social work team or our OT team, so that they're aware. And one of the principles is digital first. Where would a digital solution really work? Clearly, it's not going to work in every situation, but technology has moved on so quickly and so far. There's a whole range of things that we can do there. Okay, so moving on, carer service, really, really important. I'm sure everybody's aware. If our informal carer network across the country stopped tomorrow, the entire country would grind to a halt and our NHS would cease to function because it would be swamped, as would social care. Absolutely vital that we support our carers in Lincolnshire. We need them. We need to give them a priority access to support to make sure that we keep them as fit and healthy as possible for their own health and well-being and mental well-being, but also because of the fantastic service they provide. We've got a very large number of young carers as well. We need to support young carers, and so we commission a service from Carers First around all of these different groups. You'll see some of the areas we cover. Again, lots of more detail behind this that we'd be happy to share, happy to come back to scrutiny and update you on. It's another area that we are looking at recommissioning at the moment. We've got lots of our areas. And one of the key things we want to do, I've presented these all as separate items because they are, and they're all separate contracts. But what we need to do is articulate how they all fit together, so the people of Lincolnshire understand what's available for them at what part of their journey through health and social care, and obviously carers is a key part of that.
They are on the agenda for next month for the recommissioning of the service.
Great, thank you. And then just a little bit which will come up into the next presentation really around wider determinants of health. One of the key areas that public health is interested in is how do we help change the environment that people live in? So how can we, for example, get more cycle lanes? Because if people cycle, clearly it's good for their health and well-being, it reduces traffic on the roads, it helps us hit our carbon net zero targets. It's a win-win-win situation. So we do a chunk of work around the much wider determinants of health. This presentation isn't about that. Again, happy to talk to you a little bit about that. But it just gives you some of the areas of the work that we do. We also spend about a third of the public health grant in children and young people. And there's a huge amount of work we do with schools, as you would expect. So I won't go into the detail, happy to do that another time. We have talked a lot about how we help people stay in their own home for as long as possible. There's also something about we need to make sure those homes are suitable for people to stay in, and that's what the Homes for Independence blueprint is. We've got the Housing, Health and Care Delivery Group, which is a subgroup of the Health and Wellbeing Board that Councillor Bowkett used to chair, and they've produced the Homes for Independence blueprint for Lincolnshire. In summary, I think what we can do to try and help people is we can adapt their home so it's fit for them. We can help them to adapt so they can stay in their home, or we can create a new home for them that fits their new needs. And they're the three areas that we tend to look at. And the Homes for Independence is a bit of the changing the homes, but it's also a lot about building new homes for people in Lincolnshire. Really important for individuals who need maybe wheelchair accessible rooms, but also really important in terms of making sure that we are freeing up housing stock for different people at different life course stages, because very few of us buy a house that would be suitable for you in your 20s and then your 30s when you start a family, right the way through to your end of life. And so we've got to recognise that and either build houses that you can live in through as you change, or make sure that we help people move and there is housing stock available that meets their needs. Now, clearly, housing is a district council responsibility across Lincolnshire, but we work really, really closely with our district colleagues on this agenda, as we do on a lot of what we've just said.
Councillor Mike Clark, you want to ask a question?
Yeah, very interested in the various programmes that you're instigating and putting forward. Could I ask, are you, before you try to, as it were, invent the wheel for Lincolnshire, are you going out to other authorities and picking their brains in order that you could save time, but maybe solve a problem in a slightly different way for the benefit of the county?
Yeah, absolutely. One of the first slides in the distance past when I started the presentation, the core principles are what's the evidence in these areas, and one of the key ways we do that is we talk to our neighbouring councils. We also talk to other councils that are quite similar to Lincolnshire, so large, dispersed population, rural, coastal, and actually the Chief Medical Officer's annual report this year is about coastal and rural communities, and we wrote a chapter in that as Lincolnshire because he came out and saw how and what we deliver. And so we are building on what other places do. I think intelligent plagiarism, so nicking what other people are doing, so we're not reinventing the wheel, Councillor Clark, is absolutely a core tenet of what we do. Why would we do anything otherwise? So another area that we're working on is called the Centre for Ageing Better. Centre for Ageing Better are lottery funded, and we bid for this. We now have it that covers a chunk of the East Coast. And in terms of going back to first principles about prevention, what this is about is 50 to 69-year-olds, how do we keep them fit and healthy for longer? How do we keep them in the workforce so that they are helping us deliver? We've talked before earlier on in the presentation about how we really struggle sometimes for workforce. Well, if we can keep people fit and healthy so that they want to carry on working, then it's a win-win. It's a win for them. Their income is increased. Obviously, they carry on paying taxes, and also we keep that specialist workforce. So the Centre for Ageing Better is all about what and how do we do things differently to keep our population, our 50 to 69-year-olds, as fit and healthy, so it's healthy ageing. How do we look at homes, as we just spoken about? How do we make sure people are in fulfilling work, whether it's their careers or whether as they think of retiring, we try to help individuals who want to carry on contributing move into other roles that can continue to provide work, and how do we keep communities connected to each other. So there's a whole range of different work. Again, happy to share the detail and happy to come back to scrutiny with more detail on that one at a later date.
Councillor Karen Lee.
Just a brief question. I think it's great work. You mentioned lottery funding. Is there any government funding or Lincolnshire County Council funding as well? Thanks.
Yes, we've put officer support in. It links into a lot of our core programmes of work as well. And it's all about how we connect things up better. The reason I mentioned lottery funding is because we work, and you'll see there, we are quite different to Leeds and Greater Manchester. And we bid for that because it's not a huge amount of money for the Centre for Ageing Better, but it gets Lincolnshire on the national government map as one of the areas that is looking at doing things differently. So when national government funding becomes available, we can cite the Centre for Ageing Better and the lottery funding, because the lottery pot is a big pot that Lincolnshire very seldom gets access to. It puts us in a good position to start to get some of that money into Lincolnshire, which is key for us. I think we're nearly there. I think just the final, this is the final slide, is just to say a lot of this is about prevention, whether primary, secondary, tertiary prevention. One of the key challenges, I think, for public health practice is that when we do our job right, bad things don't happen. So whenever I come to a councillor or I go to an NHS manager or chief exec and I say, will you invest in this? It's quite difficult, because what I'm saying is, will you invest in a service that stops bad things happening? And quite understandably, that person will say, well, prove it to me. And I'm then being asked to prove something that doesn't happen. I have to prove a negative, which is really, really difficult. We all, I think, would agree that keeping people fit and healthy is a good thing to do, but it's very difficult. We spent the best part of 60 years trying to develop the evidence base around smoking, stopping people smoking, and it took probably 30, 40 years to get a really strong argument there to say if we stop people smoking, then we stop lung cancer. But what we probably only about 15 years ago could demonstrate is if you stop people smoking, you stop cardiovascular hospital episodes within the same year. So evidence is really quite difficult. It's much easier to say, somebody's gone into the hospital, we need to fix them and push them out again, because we can count those. How many people are in beds? Shall we put more beds in? And completely understand that. But the key principle around prevention is, if I do my job right, we'll be closing hospital beds. We'll be closing hospital wards. Dare I say, we might be closing hospitals because we won't need them. Now, that's fraught with political tension, I understand that, but it's the right thing to do. Prevention works. We have an evidence base. If you are fit and active in your middle age, you are far more likely to have a reduction in cancer. Why? I've been doing this for 25 years. I can't give you the detail. I do know that your T-cell response is going to be better. I know your cardiovascular response will be better. I know there'll be a lot of biological determinants that might help, but nobody can give you a perfect model. But we do know it works. So the key priority there is we need to improve our physical activity, our diet and nutrition, and that will reduce the impact on our health and social care services. So key message there, I guess, is prevention works.
Just out of interest, have we taken through item 6 as well in the role of your, has that dealt with both, or have you got more to do on the role of?
There is another presentation, I'm afraid.
Right, that's fine.
I can go very quickly through that one.
Yeah, no, that's fine, that's fine. And what was the obesity rate in Lincolnshire?
Well, if we start with reception school, about a quarter of reception school age children are overweight or obese. By the time they get into year 6, it's about a third. And I haven't seen the most up-to-date data, is between 60 and 70% of adults are overweight or obese in Lincolnshire. That's pretty well in line with the national numbers.
Yeah, okay. Yeah. Karen?
Thanks. Brief comment, and I'm sorry to be such an anorak about this, but it's what I do. I'm a cardiac nurse, and smoking is the single biggest risk factor for cardiac ill health. It really is. And just to say as well, I'd be the last person to want to close hospital beds too, but it was always the founding principle of the NHS to prevent ill health. It wasn't to treat it, it was to actually prevent it happening at all. Thank you.
Thank you. Right, shall we go on to your role then, Derek?
I did apologise before about this. This is quite a lot. So I will whistle through this. What I've spoken about is some of the wider roles that I have, but there are some statutory responsibilities that upper tier authorities need to discharge in terms of public health. They either rest with me or with the council, and that's what this presentation will very quickly talk about, and I will whistle through. So public health, we've talked about prevention, but basically public health, as the World Health Organization will describe it, it's both a science and an art. So we keep lots of data, we look at pathway redesign, we use the best evidence that might come from cardiovascular surgery, or it might come from cancer medics, or it might come from smoking services. But we also have to convince people to change, and that's where the art part of public health comes in. But the fundamental principle is to prolong health, but it's not just about more years to your life, it's more life to your years, which is about prolonging your life, but making sure you live in a healthy state for longer as well. To do that, we have to prevent ill health, and we have to do that as individuals, but also as societies, which is why public health is back in local government, because that's where really we organise our efforts as a county. I might get told off for this, but is the National Health Service a National Health Service, or is it a National Sickness Service? Does it predominantly treat people once they're sick? I think the answer is yes. Does it want to be a National Health Service? Yes. But how can it do that when everybody's coming through the door and clinicians have no time to look up? So we have to slow the rate of people going into the health service so that it can start to look more broadly, and that's some of the core principles of the integrated care system. Key difference, and then I'll whistle through some of these slides, is that if I talk to an individual clinician, their job is to give the best care to the patient in front of them. That is their registered responsibility, and they can be struck off if they don't do that. My job is to get the best care for a population. And what that means by definition is sometimes saying no to an individual. So we get requests that come into the NHS for very expensive treatment that might be experimental. And the NHS asks me and my team, people like Lucy, people like Andy, to look at it and say, should we fund this treatment? And we predominantly will say no. Individual funding requests, predominantly we will say no. Because if we spend £60,000 for 3 weeks worth of treatment for somebody, that's £60,000 that's not spent on something else. There's an opportunity cost. And until and unless we have the evidence coming back to the science that this outcome is better at a population level, then we will say no, because we know we can get a better outcome at a population level. It's a fundamental difference between public health clinical practice and every other clinical practice. It's a real difficult thing to do. Nobody wants to say no to somebody's treatment plan, and the clinicians involved want you to say yes. But our job is to look at the population as a whole, and that's the 750,000 people in Lincolnshire. So it's worth this scrutiny being fully cited on. That is a difference. And it often means quite difficult conversations for us. But it's part of our job. Okay, I'll zoom on. We've talked a lot about health improvement. Healthcare, public health is where we help the NHS and other partners improve what they do. And health protection, broadly speaking, is split into two bits. It's response, which is obviously COVID, but it's also planning to try to stop bad things happening, and that might be environmental health hazards, making sure that they don't happen so that we don't get poisonings or radiation leaks, things like that. If you want to just click through, and there's a few areas there. Always important to look at the money. And this is just a bit of a reflection. In 2021, these numbers are inflated by about 60 billion. And these are all billions. These aren't millions. These are billions, 1,000 millions. Department of Health and Social Care, as it is now, £212 billion in 2021. That was an extra 60 billion for COVID, of which about 130 goes to NHS England, of which the majority goes to clinical commissioning groups who spend it on sickness services, so GPs, hospitals. So of that 212 billion, 4.2 of the 212, 4.2 comes to Public Health England, of which we get as local authorities, across all local authorities, about 4 billion. So we get less than 4 billion of 212 billion to stop people getting sick in the first place, and we spend the vast majority dealing with the people once they're sick. Really important challenge there. We can't stop spending the money dealing with people who are sick, but you know, I would argue, and I always will, that we should spend more stopping them getting sick in the first place, because then we could free up some money that side. And we've got to remember that we've got an ageing population as a country and as a county, so that's going to result in more ill health. We've got the figures at the moment. Normally our public health grants are around 30 to 33 million. It's been inflated to some extent because of COVID, and what you'll see there is I also discharge, as we've talked about, a number of functions on behalf of the council. So about £45 million is the money that I have responsibility for. It's nothing compared to Ros. She's the money bags. But again, it shows you that balance, that we spend a huge amount, understandably and quite rightly, on social care, but we spend a good amount of money, and certainly a lot more than a lot of other councils, on public health and prevention. And favourite quote, an ounce of prevention is worth a pound of cure, Benjamin Franklin. We all nod, we all say yes, and then we spend all the money on the cure and just a small amount on the prevention. I've covered a lot of this, so I'm not going to go through it. There are a lot of statutory responsibilities, not least health protection. Interestingly, it is not my job to deal with COVID. It's the Secretary of State of Public Health England's job to deal with COVID, but clearly Public Health England were overwhelmed. So we are in a really fortunate position that we have a very strong public health team. We have a very, very strong health protection component of my team, with a duty desk, with health protection nurses. Most of the councils across the country don't have anything there. They might have a consultant who does some of it. We've got a really strong team. So we've been able to help our businesses, our schools, with our COVID response in a much more coherent and consistent way. And that's down to the council, through our politicians and through previous leaders, deciding to keep that money where it's needed. And I think that's really paid dividends throughout COVID. I won't go through these. If you've not got the slides, happy to share them. It just breaks down into a little bit more detail the areas that we work on. Health protection is the area that we look at around dealing with infectious diseases. Some of it's proactive screening, immunisations, so stopping people catching diseases, childhood immunisation schedule, for example. And some of it is when we have to respond, and obviously COVID's a good example, but also substance misuse, sexual health services, when we commission GUM clinics, for example. We are the funders, we are the statutory funders as a council for that. Health promotion, that's the bit about trying to get the messages across, which we've talked about, and the whole point is, if we can stop people getting sick in the first place, we improve their health and well-being, which is first and foremost the most important thing to do, but we also spend less on dealing with the negatives. You've seen this slide already. As I said, I'm quite happy to plagiarise my own slides and use them twice. Prevention does work. We've got the evidence base there. We have a fundamental responsibility and a statutory responsibility to support our NHS partners and advise them about what they should do that's evidence-based. And a big part of my time and my team's time goes into that. And we'll come back, and I'm sure we'll talk a lot about the integrated care system we do through the Health and Wellbeing Board as well. A few slides here that really talk about, so what are the key challenges for the population in Lincolnshire? We know that what we know, and it comes back to that conversation we had about population health management, we are, as a country, probably world leading in knowing what people die from. But from my perspective, it's a bit late. So I need to know what people are living with, and I need to know what risk factors are there that we can influence so that people don't die from different diseases. The ideal state being people are born, people live a long and happy life, and then they have a very short illness, and then they die. What we don't want, what nobody wants, is people living a long and healthy life. So in order to look at that, we've got to start to prioritise, and this is where it gets really difficult, because we collect huge amounts of data on things like cancer, on how many people die from cardiovascular disease, how many people have a heart attack. But it's quite difficult to compare how many people have a heart attack to how many people have a serious mental health illness. We can look at raw numbers, but that doesn't really work. What's the impact on those individuals? What's the impact on those families? And that's where the global burden of disease methodology comes in. What this does is it looks at how many people have lost years of life from a condition. It looks at how many people are living a less than perfect life because of a condition and for how long. And it adds those up to give a total burden of disease by condition. And that unit can be compared. So you can actually compare number of people, the global burden of disease within Lincolnshire for back pain to the global burden of disease for heart disease. It's the same metric. It's the only metric that does this. I could bore you senseless if I've not already about the detail, but we can go into that another time. What it basically shows is that what do people die of? Years of life lost. Well, I think most of us would get most of those on the list. Ischemic heart disease being the top. Alzheimer's disease. People die of Alzheimer's disease. A lot of the population won't recognise that. Also, self-harm is quite high now. Fortunately, the numbers are quite low, but people who die through suicide are often quite young, and so they lose a lot of life in terms of the years that they could have lived, and that is factored into this. So our work around mental health and well-being is fundamental, not just in terms of the next column, but in terms of people losing their life too early. So that's great. We can see what people die of. What are people living with that's causing them a problem? And this is where it's probably a bit of an eye-opener for people who haven't seen this slide before. Lower back pain is the number one, because there are so many people who live with it. And for any of us who've had back pain, I've had slip discs, you'll realise just how disabling it can be. And when you add those together across our population, because we've got an older population, it is the single biggest area for people who are living with disability, and we do not have services that help people properly with living with back pain. Because the things that you think you shouldn't do predominantly are the things that you actually should do. You should be more mobile, you should be taking exercise, you should be stretching, because that actually helps with back pain, whereas the last thing you want to do when you're suffering from back pain is any of those things, and we need to change those models. When you add a couple of the other areas on there, headaches and depression in the top three. So I'd say the top three there are three areas that our NHS system is not set up to deal with properly, and yet they're the three things that people in Lincolnshire live with the most. So that's where my job is, to influence the NHS to start to change what we do so that we can tackle those. When you add those two things together, heart disease is still the number one. As Councillor Lee's already said, smoking is a big driver of that, but also overweight, obesity, and poor diet, lack of physical activity. These are all contributing factors. But lower back pain is number 2, and if you actually add number 10, neck pain, to lower back pain, it becomes the biggest issue that we have to deal with in Lincolnshire. And what this is trying to do is just refocus what we do. We've still got to deal with people with cancers and heart disease, of course we have. But we have to have better services that help people deal with the conditions that they live with, including, as you'll see there, mental health issues, anxiety disorders, depression. Next slide. some mechanisms that we have to do this: Health and Wellbeing Board, Health and Wellbeing Strategy. These are statutory responsibilities. I won't go into detail. I'm sure you're all aware. If you're not, then just have a look at the Health and Wellbeing Strategy and it will describe all of those things. Next slide, please, Simon. Yeah, so that's the Health and Wellbeing Strategy. I'm trying to zoom through here. Next slide. This is a bit of a governance slide, but it shows you all of the priority areas that we've got and how we tackle them. Again, happy to go through detail at another time. Next slide. And this is the public health plan on a page for this year, and it shows you those different areas that we're responsible for and how and what we're going to do in those, whether it's health protection, some of the statutory functions, influencing the NHS and other district partners and others, that wider determinants work we talked about, and some of the enablers that help us to do that. And then the final slide. That's what we do. There's lots more coming. We've got Health and Social Care Act going through Parliament at the moment. We know from the Prime Minister's announcements yesterday there's going to be quite a fundamental shift in the NHS and social care, and there will be funding, although obviously details yet to be examined. I spent a long part of my early career in the Department of Health. The Department of Health always talked about the system in three components: the NHS, social care, and public health. I think we need to recognise that all the announcements yesterday, I haven't read or seen any mention of public health, and we are still in a global pandemic. So there is a question there about what and how do we maintain that focus on stopping people getting sick in the first place, because otherwise we'll just keep putting money in the other end. And obviously that's something that as a Director of Public Health and as groups of Directors of Public Health we are pushing the government to do. It can't just be, it must be, but it can't just be social care and the NHS. We have to spend more and influence people's behaviours and provide support for them so that they need less social care and less NHS services as well. I'll leave it there.
Excellent. Thank you very much for that very thorough presentation. And I mean, it really is. Prevention is better than cure, there's no doubt. Right, I've got Karen first.
I'm sorry to be an anorak about this, but I am really interested in it. I've noticed at work, our patients come from all over the county because I drive to my sister's in Spalding and I recognise loads of those names of little places. And the thing that always surprises me is there doesn't seem to be one or even a few factors. You'd think it might be about people living in one area, sort of access to the NHS, to healthcare, or poor housing, or perhaps social class. And whilst I think there's clearly a link between social deprivation and ill health, it's not the overriding one, and it's not the one well, that's what I'm asking you. Is that what you look at, the determinants, that make people ill and therefore plan your service around them? Is that what drives it? Thank you.
It's a combination. You're absolutely right. It's never straightforward. The single biggest driver is deprivation. And so if you map, we've got maps in other presentations where you can see where the highest levels of deprivation down the East Coast, in Lincoln, in Boston, but also scattered around as well. But in a patch like ours, rurality is really important. And that has a really significant impact. And just read the Chief Medical Officer's annual report this year, really picks up on that. We have to deliver our services fundamentally different, especially in Lincolnshire. We can't just carry on with one or two big hospital sites and GPs who are overwhelmed. We have to have fundamentally different services, and that's for people who've already got disease. We also need to focus on children, young people, to stop them getting disease. And so we're one of the few places in the country that still have children's centres. We fund that out of the public health grant because we genuinely see in places like Skegness, the children's centre is fundamental, it's vital to communities. And we go in and we deliver our childhood immunisation schedule in there because it's a really good chance to get people together. But as you'll know, Some people will have, they'll be overweight, they'll smoke, they'll drink, and they'll be from the most deprived communities. Others won't be any of those things, but will be from the most deprived communities. And equally, people who drink to excess, but not to the level where they need specialist support. The most at-risk group are middle-class, middle-aged women. So they have access to alcohol, they have enough money to drink alcohol, and they don't recognise that they're drinking to excess. So it's never straightforward, and that's part of the complexity. If you're an orthopaedic surgeon and you're looking at a new hip replacement, well, you've got an old hip replacement, and you're looking at how do we make it a little bit better. It's complex and it's complicated, but it's a new hip. If you're trying to stop somebody fall, there could be 1,000 different reasons why that individual falls. And that's where the complexity comes in.
Okay. What I would like to put forward to the committee is that, having just heard all of what we've just heard, and prevention is better than cure, obesity and overweight at the level it is at, with primary prevention, the one thing we can do is signposting and information. And when we look at how can we therefore intervene and help with the health of the nation, because of the more we actually stop people coming with issues, the more we relieve the service pressures. When we take the sort of overweight, we'll rebrand it and call it health and nutrition in a sense, because it all links in. There are key elements where we can intervene as a council, because nationally every child has a weight measurement, which Derek is involved with, and every adult has a health check somewhere in the system. And so there are two interventions. We've got also, as we've spoke earlier, about the comms team and how we communicate, etc. Now, I'm involved in agriculture and food, and I've been looking at the sugar levels within food lately. And actually, when you go on the NHS national guidelines for sugar, and it comes in two forms, free sugar and sugar in sort of what you call milk and fruits and etc. Now, free sugar is in effect your white sugar, your brown sugar, what's in your Coca-Cola and all your drinks. And that's 30 grams a day. Now, I just thought I will do an analysis of what sugar intake I have actually taken on a daily basis. And I whacked in at 90 grams a day. And my 3 coffees alone actually wiped out the 30 grams of sugar that I'm meant to have. Never mind the bowl of Frosties, which sits at 15 grams, followed by the lovely juice that I think is really ultra healthy for me, whacked in another 15 grams. Then I piled the ketchup on the plate, which whacks even more in, and then you have the baked beans, never mind the sweet and sour sauce that I put with the chicken. And actually, when you start to really analyse it, you really are whacking in the sugar. Now, when I go to the supermarket and I see the kids sat there eating a whole packet of Bourbon biscuits, taking in their chocolate muffins and half the bakery products, actually sugar is perhaps the biggest contributing factor to the whole overweight system. So we do have quite a few mechanisms to address sugar. There's an app, actually, that you can basically, I've put it on my phone, which I downloaded, I don't know if it's NHS, Public Health, but you can scan your cereal and it will tell you how much sugar you really are having. And I'm thinking, do you know, we can actually do something about this more locally. There is all the obesity strategy coming out, there is the food strategy being done at the minute, and I think that actually what we can do here is set up a working group to just have a bit more of a look at this, because if you look at parents and families, you've actually got 2 generations in one household generally at any one time, and therefore the young can help the older and the elder can help the young. And actually I sort of spoke about this with Derek's colleague, and actually there is a lot of work going on with this. And I think that if we perhaps set up a working group to have a look at obesity and overweight and the sugar content and see if we can actually help to really drive this forward a bit. We have everyone walking into a supermarket, but I tell you what, unless you really know what you're looking for on the back of labels, you've no idea really on what's going on. And our supermarkets will work because they want to help sort this out. And we've got like Lincolnshire Co-op and things. So there are mechanisms, I think, that can be done. And as you say, let's have a look at what else is going on. We've got other mechanisms across the country. And I think if we look at a working group, we can see if there is anything, first off, that we can do to help support Derek and the team, if there is anything that's not missing. And I think if we look at that and then we see what comes out of that to whether we want to progress that into a task and finish or a scrutiny review or further enhance it, whether we need to. But first off, we perhaps want to just look at actually the basics and see if we can't help actually start to really deliver on something. And with sort of the whole of the sort of overweight sugar content, it's perhaps a good start on this whole prevention strategy. Any views? Yeah, Andrew, then.
Yeah, as somebody who struggles with weight, I did lose 3 stone, and during lockdown, I think I put it all back on again. I'd be happy to be a guinea pig for this because I want to get my 3 stone off again. I'm quite happy for you to use me, and then the pressure's on me to lose my weight. But if I can help in any way in that way, it'll help me as well. But my clothes rail is like a shop rail. It has all different sizes on depending on what stage I am at the time. But I'm happy to be involved. Thank you.
I'd be happy to take part in any working group that is involved in this. It is a serious issue. And I noticed that, for example, if a child goes to school and they appear seriously undernourished, things will happen and action will be taken. But at the moment, the reverse doesn't apply. If you see a child that is seriously obese, as we do when we go about, as you say, Chairman, when you go to supermarkets, under the current system we have, no action is taken. And it just strikes me as odd because obviously that child is going towards serious ill health in the future.
And it is one of those, actually, if you're not careful, you rock into, and poverty does come into this, because actually, if you haven't got a lot of money, you tend to eat stuff that has got more sugar packed into it. So I think the best thing perhaps to do is we'll put it on the forward agenda. Derek?
I was just going to say that I know Councillor Woolley is leading through the Healthy Weight Partnership very similar work, so probably it would be worth having a chat, Councillor Marfleet with Councillor Woolley, maybe trying to align the two so that we can discharge it all in one joined up way. We can do both, not a problem, but the simpler the mechanism, I guess, the better from my perspective. And I've already got Andy Fox's one of our consultants in public health leading on this area and tied into all of this. So there's a lot of work already being done, but we can supplement it with a focus on sugar subject to that conversation. So I'd suggest if you have a chat with Councillor Woolley, the good thing about that then as well is we're tying into the Health and Wellbeing Board, and that is also going to, or is now, the ICS Partnership Board. So it's just simplifying a little bit.
Yeah, I think what we'll perhaps do is we'll put it on the forward agenda. We'll organise a meeting where and we'll send an email round who wants to join. We'll all have one meeting to start with to make sure that there's no overlaps. We'll invite you, Derek, obviously, and your colleagues, just so that Sue Woolley, and just get a game plan to seeing what's missing, what isn't, and have a general discussion. And I think, like you say, a sugar focus really is a key one that I think is really missing in the public domain, and especially when people go out food shopping.
Thanks, Chair. It was sort of for after that, actually. I just wondered, I've got no problem with long meetings, but can we have a comfort break after this, please? Just a brief one. Thank you.
Thank you, Chairman. My question was nothing to do with the sugar topic. Back to the paper, unless anyone else has anything on that. It was just in regards to page 28 on Appendix B, in regards to the finances. So 5.8, that's a big category for miscellaneous, so kind of a little bit more what's actually included in that. And then I was surprised to see 5.55 million on substance misuse in relation to the 1.8 on carers, when we've already spoken about the high number of carers. And obviously I know that there are a high number of people that has issues with substance misuse, but I think that service is still very reactive rather than kind of early, much more prevention work. So just kind of a little bit more from you on a couple of those points, please. Thank you.
Sure. In terms of the miscellaneous, that's got quite a lot of detail in, so happy to provide a bit more information outside of this meeting. Pam's got all of that down to a low level, but the way that we have to report through to central government gives us headings, really, and a lot of that's fine, but some of it doesn't fit because Lincolnshire, we have certain challenges that other places don't, and so the government doesn't have headings, so we've put them in there. That explains that bit. In terms of the substance misuse service, it's a statutory responsibility on the council to deliver substance misuse services, just like sexual health services. Home Office, as well as Department of Health and Social Care, and obviously Police and Crime Commissioner. That's why we spend the money that we do, given the level of need. So it comes back to that distinction between dealing with problems once they've manifested themselves, which is what generally happens with that substance misuse and alcohol service. So we have to deal with the problems as they are there, as compared to trying to stop the problems happening in the first place. If we got more money from central government, I would be very happy to look at the carer side and the preventative side, rather than increasing our treatment services. But fundamentally, we have to treat people who turn up with substance abuse and alcohol services. It's a statutory responsibility, just like the NHS has to treat people who turn up in A&E. So I think that probably describes some of that. The ideal would be to significantly reduce the demand for substance misuse and alcohol services, and we've got a whole programme there that we do. Happy again to brief either individually or through scrutiny in the future on our substance misuse services.
Okay, what I propose then is a 5-minute quick break, and then we'll carry on with item 7. And I'd just like to thank you, Derek, for all your input into that, and we'll shape up something on the weight and the sugar and etc. So, brilliant. Thank you very much. Thank you. Okay, welcome back. We'll go on to item 7, the report of the Local Government and Social Care Ombudsman. We've got Ros and Pam leading on this. Do take it as though we have read the reports, so we don't need to go into great detail, but if you'd like to just give a quick overview, then that's good. Thank you.
Thank you, Chair. There's two aspects predominantly to this report. One, how the money flows around, which I'll pick up, and then the practice aspects, which I'll then pass across to Ros. I don't know if it would help, so I'll just pick up, if everybody's comfortable with the difference between a net payment process and a gross payment process. So basically in a net payment environment, sorry. Wait, am I not loud enough? Oh, there you go. Is that okay? So in a net payment environment, which is the one that we're in at the moment, providers collect service user contribution on the council's behalf. Sorry, moving away again. So basically the service user pays for their contribution directly to our residential providers. We then collect we then pay the provider what our contribution for their care is. So each provider has multiple income streams going into them. In a gross payment system, what would basically happen is the council would pay the provider for the full cost of the care provided. So the core cost, the third-party top-up, anything associated with that individual. And then the council would collect the contribution from the service user. So the providers, for example, would have one flow of income from the council. And then it's our responsibility to collect from the service user. This is a move that will be welcomed by providers for that reason. And will play a key part, obviously, of the residential contract that comes in April 22. The reason this is a focus here, though, is where a service user, for whatever reason, and there are a number, isn't paying their contribution into the provider, providers should come to the council at that point. Some do, some don't. And that's the challenge that we've got from a financial flow. It may also be helpful just to provide a bit of background, because in 2018, the council did make the decision that our systems and processes were not robust enough to move to a gross payment basis. And a lot of work has gone on within adult care to change that. These are detailed in the executive report, October 2020, which the link is in the report itself that's in front of you today. But in brief, in 2018-19, we saw the reduction in time it takes to complete a financial assessment. So that financial assessment is done for each individual and determines how much a service user will pay for their care, but also how much the council would pay for their care. And obviously there's a lot of that in the news at the moment. But back in 2018-19, that was taking on average 20 weeks, which is an unacceptable length of time. It now, in the majority, is done within 28 days. So that was the first priority that we had to do. 2019-20 then saw the introduction of the adult social care policy to make sure that the way we're charging and how we're charging is aligned as it should be to the Care Act. Obviously, you've had a paper already on some aspects of that. But that year also saw a number of our system changes. So we've gone from 4 systems to 3. And now we're trying to move those systems for 3 systems that talk to each other and not 3 systems that you can't actually interact with. The move to gross is a huge project, and it has several interdependencies, all of which we need to ensure are operating effectively before we move to a gross. And from a financial perspective, that's because we are dealing with £26 million of income in just 1 year from the service users and others, and £81 million of expenditure. So all of our systems has to monitor all of the intricacies of that financial flows. The 4 fundamental work streams are detailed on page 43 in the report. But again, briefly, the first one is to create a master client database. So we are having to have 3,000 individual discussions. We've got 3,000 people in residential care at the moment. We have to talk with each individual and or their representative if they haven't got the capacity to act, and or family members or friends that are paying third-party top-ups or other intricacies on their behalf. And we have to work with them basically in a black and white terms to say, please stop paying your long-standing financial relationship with your provider. Stop doing that and now pay Lincolnshire County Council. We have different arrangements in place. They pay by cash, they pay by card, they pay by direct debit, they pay weekly, monthly, daily, annually, some not at all. So those conversations are quite complex to have. We now know who those individuals are. We know where they're acting on their behalf or not. We understand which home they're now in. So the first thing that we did was create that data set, and as of this week, all of the what we're calling a provider register is being distributed to the 282 providers that we're also going to have to liaise with. And basically what that provider register does is enable us from now right the way through to transition to gross is to understand who's in their care and how much the provider's cash flow is, because we're going to have to maintain their cash flow throughout this process. We don't want any confusion that, you know, as of such and such a date, it's not the service user that's paying that contribution. Actually, it's LCC. So if the provider has any queries or challenges, they don't go to the service user. They need to come to LCC. The third element is the continuation of the debt review programme. Because we've got an additional £21 million worth of income when we've transitioned to gross coming into the council, we need to ensure that we bring that income in as efficiently and effectively as we can. We will aim to work with families to get it through direct debit, but there will inevitably be people who want to pay an invoice and other aspects. Therefore, we need to make sure our debt position before we move to gross is as efficient as it can be. And we are reviewing and are on target to review all debts over £25,000 by the end of March 2022 and implement any associated changes that that review may bring. The fourth bit, and is quite fundamental, is we are running on a quite old version of Abacus. Abacus is the system that creates the charges currently for non-residential service users. It doesn't create it for residential, which is one of the reasons we don't operate a gross system at the moment. We need to upgrade Abacus to enable that charging to occur. If it's not upgraded, it wouldn't tell us how much from that financial assessment, how much each individual owes. Nor would it enable us to change the payment to the providers to the higher amount. Because they're paying net at the moment, under a gross, we'd pay them the full care. So that's quite a critical upgrade for us, which at the moment is due to have been completed by December 2021. One of the focuses for the Ombudsman as part of this report is the pressure that we have seen that's applied between the provider and a service user in a small number of cases. And this has arisen where a service user hasn't been able to pay their bill into the provider, and the provider, for whatever reason, and again there are many, hasn't come into LCC. And that is what we've seen as one of the themes through the Ombudsman's reports. What we're able to do, though, is we don't have to wait for the gross payment system to come into being to sort of intervene and prevent that from happening. One of the key aspects of the provider register that's going out this week is to identify, out of the people that are residing in each care home, what is their current level of debt to that provider. So the provider is going to declare to us, for a better phrase, how much is owing, and if there is a challenge in that getting paid, then the council will then put some processes and bits in place to keep the cash flowing into the provider and work with the families to understand why that cash isn't flowing. And we will have a good understanding of that, we think, by December, by the time all of the 282 provider responses have come back in, and we're running that every month. So that won't be switched off now, really, until the gross process is fully embedded. We have, and you'll see in the wording in the report, the Ombudsman is using words like, please can you urgently move to a gross payment system, and fully understand why he's doing that, exactly for the reason we've just talked about and the potential pressure. We are moving as fast as we can because we do recognise the need to change. We recognise it will be a far easier process on providers and their families and to be fair, the council. But our priority is to transition at a pace which ensures the financial security of all involved, the 3,000 individuals and their families, the 282 providers, and to make sure that we have full clarity on who's acting on whose behalf, and to minimise as much as we can any disruption to a service user's financial position, a provider's financial position, and of course the council's. I think that's the key bits on the money flows. Happy to take any questions or pass to Ros to pick up on the practice elements. Thank you, Chair.
Thank you. The main thing here is we need to pass any comments on to the executive. Right, I've got Councillor Nicky Clark and then Councillor Trevor Young. and then Mike.
Hiya, I guess my question is around the gross payment system. Before you introduce it, and I know that will have taken a lot of work behind the scenes with the IT and patching and putting everything together, will you run a test before you actually run the gross payment system so that you haven't got any anomalies out there and everything's kind of gone wrong with the data?
And just on that as well, will the new entrances go straight onto the system from the start?
So yes, first because it's the easiest, yes they will. Anybody that's new into care will go straight onto a gross payment mechanism, absolutely. With regards to the testing, yes, we have weekly tests now running all the way through, actually between LCC, finance, IT and our Servelec providers, to ensure that all of the changes we're doing between now through to gross and for the next 3 months on are tested and they all balance before we move. So we have a test environment where we can pre-run it first and then we will push the button when we are confident and we get a 98% response rate at least.
Thank you. Trevor?
Karen, could you just explain the difference between an assessed user contribution? Sorry. Could you just explain the difference between the assessed user contribution and a third-party top-up? Because they are different, from what I understand.
Can't get used to this microphone. Yes, they are, but they are very different. Yes, so each individual that enters care, residential, non-residential, or any type of social care, will have a financial assessment which takes into account the value of their assets. And at the moment, anybody over £23,000, as we'd heard earlier, will go in as a self-funder. Anybody under 14,000 will receive free care, and anybody in the middle is means tested. That's obviously going to change. Anybody under 20,000 will receive the free care. The means tested will be between 20 and 100, and now that will be capped. The amount they pay, that is called the assessed contribution. There are instances, though, where another party, not necessarily the service user, can decide to top up that fund for a variety of reasons. That's called a third-party top-up and wouldn't be necessarily paid by the service user. We will, through this process, ensure that we cover both the core payment as well as that third-party top-up. So again, we're trying to make it as smooth and efficient, both for the service user and their families, but also for the providers, so that the administrative burden from a provider perspective would actually now be borne by ourselves as the council. And again, same for the service user and the family.
And the top-up will be paid direct to the provider?
That's correct, yes.
Okay, thank you. Mike?
Sorry, just a bit of delay in getting online. Did I hear you right that there are over 200 providers of the service?
282 individual care homes that we are working with across the 3,000 service users, yes.
Going forward, do you think that number is going to increase, obviously, with the ageing population? And would we have the capacity to deal with that? And similarly, there was obviously errors before. In going forward, are you going to have a mechanism of a 5% check or a 10% check to try and eliminate any errors that would fall on us?
Yeah, so I think there's two questions there. Glenn might want to come in on the provider market. Obviously, we've seen significant shifts in our provider market and the level of beds that are occupied, etc. And we're still waiting for that to settle following the COVID-19 pandemic. We're not expecting a huge increase in residential care beds. And as per Derek's discussions earlier and the wider ambition across adult social care, it's actually to maintain people's independence within their environment for as long as possible. So I think an increase in care home beds would obviously be a contradiction to that. The second element around how are we going to monitor this going forward, we are bringing in now full, what I call whole person reporting. We've done very well, and it's again very similar to how Derek was presenting public health. We've done very well in saying this is non-residential, this is residential, this is daycare, this is very much like Derek's slides went through. What we actually need to say is that service user and their family are interacting with a number of our services at the same time. So they get letters around a number of things at the same time for their financial position. What we need to do is see them as one person, an individual with a family, and we need to be able to work with them across their entire financial position and what's happening with their finances, as well as care needs, etc. So one of the things that we're trying to support from a financial perspective into the services is to adopt that whole view approach of the service user and their family instead of an individual approach.
But in doing that, will they or hope to eliminate any mistakes whereby we are, taken to task and the omnibus comes back at us?
That's the plan. Can't say we can eliminate them, but the plan would be we'll minimise them as much as possible.
Thanks. I just want to say that the whole process is, for most people, incredibly confusing. I'm a registered nurse who's discharged hundreds of people, and I'm a politician who's worked at the highest level. And when my mum was ill, the first time she was discharged to a residential home, it was under something called the COVID payment, which no one ever really explained to me, but it covered her for 2 weeks. And she's, by the way, paying £850 a week out of money that she worked all of her life as a teacher for. I think it's shocking. Yeah. And now, because she then had to go back into hospital because she fell in the nursing home, but she's gone back, the residential home, sorry. She's gone back. She's not now on the COVID payment. She's in there. And because she's also lost capacity, I think we're on deferred payment. But this is what I'm saying. I don't really know where we are. All I know is I've had to apply for court of protection proceedings, which are incredibly complex too, and which also cost, I think, about £3,000 they've told us it's going to be. The whole thing, I mean, we're lucky. We have got a little bit of money, myself and my siblings. If we didn't, I just wouldn't know where to start with the solicitors stuff. I'm not really clear who's paying for what, but I know we're going to have a whopping great bill when I finally do get to be able to get to her savings in what I'm told is at least 6 months' time. It's a real minefield, and I don't feel that what was announced yesterday makes it any better, because they've actually lowered the threshold at which you have to fully fund from 23,000, or they will be doing from 23,000 to 20,000. That's when you start self-funding now.
No, the 20,000 limit at the minute anybody under £14,000 is free. Now it'll be anybody under £20,000 is free. That's where the 20
Where does
comes
23
in.
come into it then?
23 is your current limit.
Right. What I'm saying is, though, I've worked with this and it's incredibly confusing. So I just think there needs to be some help out there for people to understand it. That was my point.
Yep.
Yes, thank you. Pam, could I just ask you, when we go over to the gross payment system, while we've been on the net payment system, obviously some care homes, I think it's been mentioned, have obviously some families have got into arrears on the net system, and the care homes haven't got those arrears in. Who will be responsible for the accrued arrears when we go over to the gross system? Because obviously it could be quite, I imagine it's quite a big amount of money.
Yes, the Care Act is clear that the local authority is always and always will be responsible for that. So we do have, in the residential contracts, we have the ability for providers to come into us when that doesn't happen, and some do, but it's an unknown to us. So I can't sit here and say on 100% of occasions they have done that, because obviously from an ombudsman's position they haven't. So we are waiting till December when all of the returns will be back from providers to see if there are any amounts that we don't know about, but we have got it as one of the key risks to the move to gross.
So if they haven't told you about it, are they then responsible, or are we still responsible even though we don't know and nobody's told us?
It is the local authority's responsibility to make sure care is funded.
So why haven't they been telling you when people have got in arrears? That's a bit I can't quite get my head
I don't know,
round.
but I'll ask them the question. Like I say, some providers do. We just don't want to make an assumption at the moment that some providers haven't come to us. When we've worked, we do, again, very similar. We've liaised with a number of local authorities, around about six who've already moved to gross. And one of their biggest warnings was, please don't assume that all providers have come to you. It was something that happens nationally, not just to
I can
Lincolnshire.
imagine they're going to be trawling back through the records to see where they've got arrears and just claiming them all back if we have to give it to them.
It would only be for people in their current care. People in current care, yeah. So if you've got an individual in their care home as we move and they're not paying their bill, it would be the current.
So they can't go back in?
No.
Right, thank you.
Come on now. For the executive, I think I would summarise this up as that this is a good thing going forward. It's going to take pressure off the providers. It has been a complicated IT in effect, which has had a massive resource to put it in to resolve to where we are with it. Going forward, in effect, on the what the Prime Minister said yesterday, it will lend itself to suit that system as well. And but I think where we need to just highlight to the executive is there is timelines issue here. There is the potential for slippage, which I think needs to be managed. I think resources need to be available to deal with the 3,000 people that need to be spoken to. I would actually say that there needs to be maybe a bit of a priority system put in place for those 3,000 people to try and get this moved over as fast as we can. And so we just, and I think there's perhaps a timeline needs to be tried to be put in place for when really this should all be completely put to bed. Any other comments, or are we all quite happy with that? Trevor?
Well, Chair, I agree with completely what you've said, but I do think there's a need for a refresh in terms of training for the frontline staff. And one of the things which Karen pointed out in terms of how complicated the process is, but one thing what is very clear is that the practitioners themselves really find this very difficult and challenging. They're excellent in terms of assessment of care. What they will admit to is that they're not, they're not finance officers, they're not accountants, and it's very difficult in terms of understanding that. I do. When I read through the report, it just came out quite clear to me that there's a training need here. So ensuring that there is a full training program taking it forward, because it is a different approach in terms of gross to net.
Yeah, I think in some sense, technically it should get a lot better because it's all handled by LCC now, and in effect that really comes down to the means testing procedure and the information given, which can just be in effect we'll put forward that it can be double checked just to make sure it is in language that actually people understand, i.e. English. Right, quickly.
Yeah. Just a quick point. I've run my own business, and I know that, and I hate using this term, and it's not the right term in this context, credit control is really important for a business. And if we're going to be dealing with the gross payments and actually dealing with the families directly, rather than chasing up debts, and I hate using that word as well, we need to be working with the families at an earliest point so that they don't get into big arrears, and if there's a problem, identifying it early on, because it is so stressful for families, as we all know. Thank you.
Right, thank you. Karen, and then Tracy.
Thanks, Chair. I'd like it to be noted for the record that 2 members of the committee did raise the need for training, and we've asked that that be put forward to the executive for the record. Thank you.
We did put in there that actually just to re-evaluate that the training was up to spec. Hold on, Tracy.
Just a quick one, Chairman. I would very much agree with you that it should actually be much easier for the family now. The only thing that slightly springs to my mind is because of the fact that we're paying the providers to then deal with the families later on, what I wouldn't want is for the family to not have it explained as much what is going to be responsible for, and it run a risk of someone needing to move because they didn't realise how much they were still going to be liable for. So I know it's important we get people into the homes, out of the beds and all of that, but as to not to rush it now just because of the fact that we're paying. Thank you.
Yeah. Okay, Nikki.
Yeah, just briefly, I think what I've picked up from my colleagues is that customer facing, when we're advising people wanting to use that service, that customer facing, not only are the systems robust, but the people have the necessary knowledge to be able to explain the service that they're asking for, so that when they contact us for this service, they understand fully exactly what they're going to be saying to the customer, and those training systems are robust and they know it. Like benefits, they've got to be able to know it.
What a lot of that has been said is actually to do with the whole assessment process and when they actually come forward. We've got to remember that going forward, when somebody comes into adult social care, in effect, they are assessed. And it's that journey and that explanation which, in effect, has got a lot better and has got a lot smarter. The whole assessment process, we've pumped quite a lot of time and energy into making sure that it is in English and people do understand it. Where at the 3,000 that we need to convert over, there will have to be, in a way that it is explained to get those 3,000 to convert as fast and as easy as we can do. And I think what we're saying and what we've said is to put in that the fact that, you know, just to make it aware that training and the fact that the terminology is fitting. Okay?
Sorry, Chair, can I just pick up on 3 points really? We are aiming to get this done by April 2022. So with a bit, Q1 is what we're aiming for, and they're predominantly April. We do have finance champions now in place within the service teams. So obviously, we do have recurring training for them, but we will be reviewing that, and I think that's exactly the point here. And then it'll be need refreshing because things, as of yesterday, do change from April 22 anyway. So I think that is a very good point. And with regards to the 3,000 people, we have got dedicated phone lines, dedicated emails, dedicated people at the end of the phone with finance and service backgrounds, so that they don't have to go through the normal CSC waiting, phone numbers or any of those. And we've got those dedicated channels in there for them. Thank you.
Excellent. Right. Well, I think we've got most things wrapped up there. Thank you very much. And I think it will come back to the committee just as a summary to where we are once it's activated. What would be a decent time that we're looking at? I suppose really it's next April that we are all ready and up and going.
Maybe June, because I think in April we'll still be doing the checks that we've actually moved everybody across. So I would appreciate a bit more time if that's okay. June-ish.
Well, it'll be July, September then, because that's when our sort of committee meetings are. So brilliant. Thank you very much. Okay, on to item 8, which is the Lincolnshire Sensory Services recommissioning, which is going to be taken by Alex Craig. Well done. Welcome, rather, but actually well done, because it is a good report, and I think you've really listened to what the users have said, actually, as I've gone through it. So their voices have been heard and noted. So brilliant. Well done.
Thank you, Chair. So I'm here this morning to, on behalf of Adult Community Wellbeing, to recommission 2 services. The first one being sensory support services. This is a preventative reablement service for adults and children who have cognitive or acquired disabilities with regard to either visual or hearing impairment, or both if they're deaf-blind. So this also includes public health as well. It's joint funded by all 3 services within the county in that respect. The current contract is delivered by RNID and has been since 2016 under the brand name of Lincolnshire Sensory Services. There are no extensions left available under the contract, so we now need to enter into a re-procurement if we wish to recommission the service. So the report seeks approval for the commercial team to enter into a competition for the services, to re-tender them in order to have the services re-procured by April next year. And the report sets out the steps that we've taken with regard to that work, so consideration of a number of different recommissioning models. One of the primary areas that we looked at was how each of the service lines were commissioned. Obviously, this involves children and adults, but it also involves the different types of sensory impairment. Previously in the past, this has been separated into hearing impaired service and a visually impaired service, but as the report states, there are clearly a number of people who are required support for both types of services. And also the way that the council works with regard, and health works with regard to these service users, means that joining them up into a single service has a lot of benefit. The provider, RNID, has been able to perform well over the last contract period. They're meeting all of their KPIs and meeting all their demand outcomes, particularly notable given the pressures of COVID and the contact limitations that people have had with that regard. So this is a vital service. It helps people adapt to new impairments. There's aids to daily living. There's support and re-ablement to help people get back to a level of quality of life that wouldn't necessarily be there without these services. And it does take quite specialist skill and support as well to be able to do that. There's the proposal for the re-procurement then is to go out to competition for essentially a similar service, a joined up single service with a single provider that supports all impairment types. That would be for an initial period of 3 years with options to extend as typical with these types of contracts. So that would go up to a maximum of 5 years. There are a few factors within the market at the moment that are worth noting. It is quite a restricted market, given the specialities that are required to do this. And I would need to note as well, the current provider, RNID, are intending to exit the market from being a direct service provider. The Institute are refocusing their efforts on fundraising and other types of activities, but there are, within that organisation, there's an initiative at the moment to launch a spin-off that would potentially offer a service provider option. We have tested the market as well, and there are other options available to us. So we are expecting a degree of competition within the market. So again, that's not unusual for these types of services, but the market testing that we've done indicates that we'll be able to run a successful re-procurement when and if that's approved. And as the chair's also noted, the feedback from service users has been is very good, level of satisfaction and meeting the outcomes that each of them have with regard to this service. So we feel that this is a good value service, both in terms of the outcomes that it provides to the citizens of Lincolnshire, but also what we're paying for as well. There were no other commercial factors that I wish to raise with you today, so I'm happy to take questions now if there are any.
Hi there. I've got 3 questions, having read the report. Would you like them individually, or shall I give you all 3? All 3. Right, okay. On the background list that you've got, I noticed there's no mention of any complaints against the organisation that we might have. I think maybe that's an element that needs to be in there, because we need to know if there are complaints against them, other than the other items listed. And on page 70 on your key performance indicators, they all look very good. But I noticed that there wasn't one that noted any decrease in activities by individuals. And obviously if someone's activity level is decreasing, that would be, I think, a cause of concern and would need some reaction by the provider. And similarly, on page 71, it mentions that there were 88% of satisfied customers, but obviously that leaves us with, at that particular time, 12% that weren't satisfied with the service. Is there any mechanism that we would ask the reason why they weren't happy with the service and then feed that back into the system? Those are my questions.
Yes, so with regard to the last one, there are mechanisms to do that, and that's factored into the re-procurement exercise. So the feedback and any suggestions for improvement will be factored into how we write the new specification and the new performance measures as well. So I don't have those to hand, but that is the standard practice with regard to any of the satisfaction surveys that we've had. And sorry, your second question was regard to which of the KPIs?
Yes, on the KPIs, it mentions all the good progress, all the advancement by individuals in various areas, but I didn't notice that there wasn't a KPI to show how many people have decreased their activities because of whatever circumstances affecting them. And obviously I think that would be an element whereby if we know there's been a decrease, to be able to go back and ask the individuals or to ascertain how best they could be helped to bring up their activity level again.
Okay, yeah, we'll take that into consideration with regard to the KPIs. Some of the KPIs do reference that to a certain extent, so increased mobility is one of the measures that we look at. But again, I think it might be useful to look at that in the whole as how overall the service users are improved, and as you say, their activity levels have also improved.
Thank you, Chairman. Coming from someone whose mum is deaf in one ear and dad was blind, I am all for the service being a one service, and I agree completely with the rationale behind it being a one provider. My only comments would be on page 70, again, those targets are on there. I find actually some of those targets incredibly low, to be honest, when I'm looking at the amount of referrals into the service. So some of those paid opportunities of work and reducing isolation. So are we setting those targets? Absolutely. Or are we being led very much by the provider at the time? And is there any adjustments on those that we'd be looked to do going forwards, as I do find them low? Page 71, delighted to see that, again, you've got the 100% of respondents overall happy with the service. And on page 72, I would say the fourth bullet point down, the potential of alignment of services and pathways have been explored with healthcare partners. Why isn't it already aligned, would be my question there. And that's it, thank you.
Okay. Well, the last one is quite difficult for me to answer specifically. It involves, as with a lot of collaborative services, joining up a lot of the machinery and the referral pathways. So that is actively being looked at now, particularly with regard to the ECLO. There's some changes afoot with that one that we're dealing with at the moment. So it is to the benefit of us in operating the contracts as well, to make that as joined up as and efficient as possible, particularly with, so the ECLO in that sense, issuing the certificates is a key step in getting people into the service. So as much as possible, the council is pushing that, and all of our teams are working on that. So sorry, if you wouldn't mind repeating the first question.
Essentially, the first one was more in relation to the targets being pretty low, to be fair.
Thank you.
My observation is which I agree with on the back to work or support to work is really low. Now, might be an explanation because it might be age related, and obviously age related in some of the hearing incidences because of age. But then there are exemptions. How many people
Yeah, I think that's something that we can be clearer about in the new contract, so making a specific element and performance measure for those who could be employed.
Rob?
Thanks, Chairman. Coming back to KPIs, again on page 70, I noticed that there's a massive drop in volunteer hours for the actual performance 2021. Is that attributable to the COVID situation, or is there some other reason that it's an incredibly massive drop?
COVID has certainly had a huge impact on that, yes. Probably the prevailing issue as to why that has happened. But there were other factors. It is quite hard in general to secure volunteers. That's the feedback that we've had from this provider and others as well. So working harder in that area is another potential area of benefit for us, certainly. But there has been, unfortunately, over the contract period, there was a breakdown in the relationship between the joint group of providers, and that had a direct impact on volunteers. Some of those more local, smaller charities pulling away meant those volunteer hours didn't appear. Now, clearly, we still want that to happen. It wasn't one of the most crucial KPIs, and given the provider had already proven very well they were meeting all outcomes, meeting demand, and also within budget, and getting the good level of satisfaction, we didn't believe at that point it was necessary to penalise them.
The volunteers has dropped off the scale. What actually was the makeup of the volunteers in the first place? Are they volunteers because they are connected in some way to the person? Or is it volunteers just coming out just because they want to volunteer? Do we understand what is the makeup of the volunteer?
I think we can understand that. My understanding is that primarily that has been as a result of registered volunteers in that sense to the local charities and organisations. So each one of those, as part of the partnership, will have a bank of volunteers, people who have registered their interest to do so, and they come along with that. But LSS do actively still try to secure additional volunteers and able to meet that target, but it is continuing to be a very hard target to meet. And although it will be something we want to continue to do in the future, I think we'll have to be realistic again about some of the targets we do set in the future with regard to employment and how people can find employment in the current workforce, because those challenges are much greater than they were pre-COVID and when these contracts were set up.
Thank you. I mean, the volunteers is, I think, an essential part of the community going forward. It is a beast in terms of how do we connect it and all the rest. And like we said, how are people volunteering because they're connected, because they're related, or they're friends, or is it actually because people from just are volunteering for goodwill? But what on the next, in October's agenda, Justin Hackney is presenting the overview of adult care and specialist services, and one of his roles is volunteers and how we engage and try and support volunteers. So I think the whole volunteer thing, we need to sort of just give Justin the head up on that one. But it is something that I think we you know, it's a tricky one, how we support it, how we can help it, LCC. Justin's doing some work, so I think we'll deal with a lot more of that at the next agenda item, on the not next agenda, at the next meeting. Right, I think, are we all good, done? So what we need is a proposer and a seconder, but first off, we need to just agree what we say to the executive. And to summarise it up, we fully support the fact it is a whole integrated package, all linked in together. Yep. Looking. We also would like just to sort of highlight whether we are, you know, just this sort of supporting, well, we would like to highlight supporting people to take to work and to the volunteers and social isolation as sort of, I think, 3 areas that we really do need to keep an eye on and somehow trying to make sure that those numbers move where we would like to see them more back on target and in the right direction. Okay, all happy with that? Tracy?
Can we also add something about that alignment as well, so it's not forgotten at all, kind of thing, on page 72? Can that be fed back to the executive as well, if
Aligning with other providers.
It was on page 72, yeah, it was got the other providers. It was the 4th bullet point down on page 72.
Yeah.
Thank you.
And just, yeah, to reinforce the alignment to providers and partners in the pathway. Okay, can I have a proposer? Rob, seconder, Tracy, all in favour? Good, thank you. Unanimous. Right, I jumped the gun on item 7. We didn't propose it, second it, so can you just read out what we actually summarised back?
So item 7 is the...
Because Simon writes them up and then I look at
as,
them and
as
then
part of item 7, yeah, you welcomed the paper and but acknowledged some of the complexities of the IT system. You welcomed that this would remove pressures on providers. You also sort of highlighted issues with the timeline and suggested that resources should be targeted at addressing or meeting the 3,000, sorry, contacting the 3,000 people who, and there are also comments on, and I think the agreement was to include references to training, and whilst there is the target of April 2022, there was also a comment of not to rush the IT, but to make sure that it is fully in place.
Yeah.
I think that was
and what I would say is training and terminology is,
yeah,
just to rephrase that, it's just to basically make sure that in training and terminology is provided for, fit for purpose. Karen.
I'm not working. Can you give us the wording about what you're going to say about training and terminology? Because I feel it's really important, and it's gone now, but I'd just like to know how you're phrasing that, because I want to be sure it carries the level of weight that we're happy with within committee.
Well, in theory, you could say training and terminology is fit for purpose where people understand it, that the users understand it. Okay? Brilliant. Right, can I have a proposer and a seconder, please? Andrew proposing, second Mike. All in favour? Thank you. Item 9, Strategic Market Support Services Re-Procurement. Alex, again, welcome back.
Thank you, Chair. So again, seeking approval for the recommissioning of a key service. This one being the Strategic Market Support Service that's been in place since 2018. Linker, the Lincolnshire Care Association, are the service provider for this one, and it deals with a pretty wide range of activities, all broadly designed to support the adult care and community wellbeing workforce, which clearly at the moment is a really important factor in how our services work, absolutely crucial at the moment. So if you're in the report, it's clearly broken down into 3 main areas. The first one being the larger one, the general strategic market support to the sector. So the service provider will offer training targeted training to all care providers within the county, or registered care providers, on a range of activities that are determined by surveys and feedback that the provider does themselves. They do a training needs analysis, and that can be on, as I say, a wide range of activities, anything that relates to how care is delivered in the community. And also there to act as a general advocate for improving the status of the workforce, the presence, and more specifically, and really, really important at the moment, is helping with recruitment and retention. The workforce for adult care is at the moment in a very, very fragile state. There's a lot of vacancies. So we're expending a lot of effort in this contract and others to try and ensure that we're keeping as many care workers in the sector as possible, and that those care workers are happy to do so, and that they're trained to the right level. So this contract's a key part of that. And the care provider works strategically with the council on a wide range of activities to help deliver those outcomes. Another key element of the contract at the moment is the Part B element. That's operationally quite distinct to what I've just described. That's the care home trusted assessor process, in which assessors will work within hospitals to facilitate discharges into the community. Before this was in effect, there were difficulties sometimes in making that process, that discharge process from hospital into care homes and nursing homes. So the care home trusted assessor works with the hospital teams to contact residential and nursing homes to help smooth that pathway in order to do that. And that's been well received by the market and has helped in that process particularly. Part C, the final element, is an innovation and initiatives section, which allows us to respond to new changes within the market and launch new initiatives. So referenced in the report are things like onboarding all the providers onto NHS Digital so that they can use capacity tracker and have access to NHS data as well. So the proposal, though, is to continue with the services more broadly, but to split them out into two contracts. It won't really change the service delivery a great deal, but it will help in terms of how they operate. Because the care home trusted assessors element is operationally distinct, it has very different KPIs and management information. Operationally, we're just going to split them out. They'll run on concurrent terms. They'll ideally be supported by the same provider. That isn't necessarily going to be the case, though. That'll be tested by competition. But I would say I'll map that factor again, and in a quite similar state to sensory services. Market is very limited for this type of support. It requires quite a specialist organisation with links to the community who understand how the system works across the spectrum, and it can have those relationships with the hundreds of care providers that we have in the county. So, but it does mean a crucial element within the council's broader effort to improve how the care workforce develops and improves and responds to challenge over the next few years, which are going to be considerable. So we are going to be making some changes again to how the contract is managed, and the level of transparency that we can see with regard to this. It's quite a complex mechanism as with regard to how the service provider operates for the council in the role that they do, but also they're an advocate for care providers, and also they do take and we require them to secure additional funding from other organisations like Department of Health, Skills for Care, Health Education England. So that's all a really key element of what makes this contract work. So we're increasing the level of transparency and accountability within the contract to be able to give us the tools that we need then to plan for the future and see really where those hot spots within the market are, and how we can then ideally provide additional support to the sector over the next few years. there is an additional amount of budget that's been allocated to the service as it currently stands, an additional £55,000 which has been secured, and that's designed to help the personal assistance market for direct payments, which is harder to reach. They don't have the traditional mechanisms as to how we interact with care associations or the council. So that's and continuing to grow as well, particularly the direct payment market. So the contracts are again designed to be a 3-year term with a 1+1 extension available. It will be a standard procurement as per the typical tendering rules, and we'll have to have that in place by the 1st of April next year. Any questions?
Thank you. Again, we need to pass comments on to the executive. Mike?
Yes, on page 110 and 113, we list the costs and the duration of the contracts. Now, I'm not trying to decry it, but it's a fairly small amount of cash overall within the council's budget. And I do feel the amount of officer time in doing and going through the contract process, should we not look at the possible alternative of making it a 5-year contract and 2-year option? Thereby, we would work with a chosen contractor over a longer period, have a better relationship, and have a better end result.
Certainly worth considering. There is a review and programme board for this activity, and it's something we can consider. I think that tends to be the typical duration of the contracts that we work to, even with the values that we're talking about today, them being a key decision, and we do factor that into our work plan and work programme. So there's adequate capacity within my team and others to do this work. And I suppose the other factor there is, personally, it's just the level of uncertainty that we'll have over the next 5 to 10 years with regard to the workforce and how the market's going to change as well. So I do agree that having that continuity and that stronger partnership is really important, but also us being able to respond to change within the market and the system more broadly is also really important.
Just on that note, I think what's perhaps the most important bit is that basically after 5 years, the chances are that the contract will want retweaking in some form, and it gives a great opportunity. And I think, you know, when you look at these sort of contracts, 3, 5, if you go too short, no one invests enough into it, and too long, you suddenly end up where you've got something that really time has moved on and it needs to be altered. So 3 + 1 + 1 does seem always a pretty good fit, all in all. Just on that, I mean, you're right, there is a chunk of money put into this contract and it does good. Some of this there is the potential though to get funding from outside rather than it always be us. And I think, is that phased into this contract?
Yes, it is. It is a performance target that the current provider has to work towards to try and match fund the service essentially, and they have been very successful in doing so. They generally, I think, at the last, and forgive me, I'm not the contract manager, the figures were nearly £80,000 a year of additional match funding from other organisations. So it is very hard to do, and that all depends on a number of variables of what's available and when that's available as well. But I think there is certainly a move from our perspective to try and make certain elements of this service more cost neutral, to focus in some of those elements and make some of the training pay for itself if possible, but not at the cost of it not being available or the quality of that training be unavailable.
Okay, so going to the executive, I think, you know, we welcome the report. I think we would like to perhaps see emphasis on recruitment, emphasis on, in effect, innovation, because it sort of sits in this pot as well. and also trying to become more self-funding. And I would say that in a sense it's their duty to sort of perhaps report back, the provider's sort of duty on how they are trying to progress on those sort of areas. For us going forward, Karen?
That's it, Amon. I was just going to say, perhaps staff retainment as well, because a good place to work, usually they manage to retain their staff, and if they've got a high turnover, it shows, and that tells you something, doesn't it, often? So I wonder if there ought to be something in there about that as well, reporting back on staff retainment and turnover.
Yeah, I mean, whether we call that, you could call that something like identify good within businesses and promote that throughout, should actually always be at the forefront. So so that's what I'd say to the executive. Are we all happy with that? So proposer and a seconder. Mike, Rob, all in favour? Good, thank you. I think from our point of view as a committee, it would be good to have on the forward agenda actually Lincolnshire to come to the committee and just show us what they do. At some point it'll fit in somewhere, but I think it'll be good to see what they're doing, how they're recruiting, how they are training and developing.
Just on that point, Chair, then, because of the timing with regard to the competition and the fact that the current provider may or may not be the future service provider, we'll just have to factor that in.
That's true. So whoever the provider is, but I think the key will be is to let them get, when's the contract due again?
1st of April next year, so we'll be starting the competition soon.
Ideally, it'll want to be sort of it's nearly this time in a year's time, really. At the earliest, they need time just to get settled in or reorganised. Okay. Thank you.
Thank you.
Okay, we'll go on to item 10, service level performance against the corporate performance framework, quarter 4. And I believe we've got Caroline Jackson online. Yes. Welcome, Caroline.
Thank you, Chair. Just to check everybody can hear me okay?
Yes.
Yep, excellent. Hopefully you've all had an opportunity to read the report. So it's page 135 in your pack. We're looking at quarter 1 performance data for 2021-22. Pages 141 to 146 have all of the details for each of the individual measures. There's 18 measures that we can report on in quarter 1, and given obviously the time that we have, I propose, Mr. Chairman, if you're agreeable, just to focus on the 3 measures that aren't achieving their target this quarter.
Good idea.
So the first measure is carers supported in the last 12 months. So there, and just to say as well, I have included the numerical value in the covering report, which was a point raised at the last meeting about making it a little bit clearer exactly how many service users or individuals were being affected by particular measures. So hopefully that's been helpful. So there has been a reduction in adult carers who've been supported, a reduction of 7.6% in quarter 1, which is 811 individuals over that period, and it actually relates to a year from quarter 4 2019 to quarter 4 2021. The kind of anecdotal evidence, obviously we have been in a very difficult 18-month period, is that the evidence from the carers service is that during the pandemic, the number of carers has reduced in terms of the level of support, the numbers, of individuals, but actually the level of support for the individual carers that do require it has actually increased. The second measure is also related to carers and those that had a review of their needs. We've not achieved the target of 85%. in the last 12 months. We actually achieved 76%. So 702 of our individuals have had their needs reviewed. Again, I think a point to make is that during the pandemic, Carers First have reached out to every single carer and ask them about whether they need any additional assistance. And those wellbeing calls aren't included in this measure because it's not counted as a formal review. So just to be sure and be reassured, I guess, that all carers have actually had a conversation about their needs, but not in a formal review kind of setting. And then finally, again, one that's been mentioned, I think, at the last meeting around adult safeguarding concerns leading to a safeguarding inquiry. So only 25% of those received actually led to a safeguarding inquiry, which perhaps indicates, again, that a point that was raised at the last meeting that is being followed up by the Safeguarding Adults Board, which is around ensuring that those referrals that we are receiving are those that are relevant, and we're working on that referral process to ensure it is fit for purpose. I think Justin might want to come in at that point.
Thanks, Caroline. Yeah, we've done quite a lot of quality assurance on the NFAs, and in particular around the quarter where it's gone up. A big proportion of those are related to police referrals and also EMAS. And we know that both of those organisations often send information to us, and they're not actually always concerns. So we're doing some joint work with, in particular with the police, around how we can do some training with them around the difference between sharing information around safeguarding and actually when they need to raise a safeguarding concern. We're also looking at the front end in terms of the referral process, in terms of being much clearer around the concern form, and actually they're, having something separate where organisations want to share information or intelligence. So that'll be one of the sort of strands of work that we do around that. But what it is important is that organisations do share intelligence with us. But what we don't want to do is overload the inbox of the triage function within adult safeguarding.
Thank you for that, Justin and Caroline. When do you think the summary of that safeguarding will be concluded?
So, I mean, in terms of the meeting with the police to look at the QA work we've done, that will follow on, that will likely be probably November time, because there's a wider LSAB audit of the referral forms and the quality of the information that people send to us, really, to look at. So we want a rounded discussion on that, and then it will go to the board. To be honest with you, Chair, it's an ongoing matter, this, that we'll never be able to, we'll never get it perfect where we get 100% of the concerned sent to us making it through to inquiries, and we make progress and then it will come back. But certainly, by the start of the new calendar year, we'll hope to have got the new referral forms in place, so that we can separate out more clearly what's information and what the concerns are, and that should hopefully make a big impact on this particular performance indicator.
Okay, any comments? Mike, Andrew, Karen?
Yes, thank you very much. On reading the report, there was a lot of information given, and I was absolutely astounded that we've got over 2,400 young carers. And because of their ages, are we giving them extra support? Because obviously they may not fully understand the process of what's available for them as carers.
Karen or Justin?
Chair, do you want me to respond to that?
Yeah, we'll cover it in the chamber.
Yeah, so in terms of the Carers First Commission service, we have dedicated support for young carers. Happy to bring forward the detail there, because as you've rightly articulated, there is a different level of support required, especially considering some young carers are still in education. A lot of young carers are still in education, so it is a different package. I'm not sure whether we've got on the forward plan carers first as an agenda item, but we can do that and cover the breadth given the previous conversation, if that would be helpful.
Okay, Andrew.
Yes, thank you. I mean, my comments regarding the adult safeguarding concerns, because 25% isn't a very good figure, and this comes up every month. So I think whilst we need to get that figure sorted out, everybody who reports something that they feel is a safeguarding concern involves someone who could be at risk. So in trying to improve that figure, what we don't want to do is put people off reporting safeguarding concerns, and that must be the dilemma here. But I do welcome the work on this. Thank you.
Karen?
Thanks, Chair. My comment was around the safeguarding concerns as well, and I take Justin's comments on board, but I would ask if we could bring this back to committee, perhaps the first meeting in 2022, just to look at, you know, what progress or how this has moved, and just for an update on where we are with it, really. Thank you.
If I recall in the minutes, isn't there something about when they're coming back to us?
Well, the report will come back quarterly in terms of performance. We do have the Safeguarding Board due to visit in December, but I think what you're specifically asking for is something on this concern, so maybe it's something I can...
If I could just say, I think it would be very helpful to have some sort of explanation as to what constitutes a serious enough matter to require an inquiry and what doesn't. I think we need a bit more information really on how that's actually determined, because each of, as I said before, each of these concerns is about a person who could be at risk. So I think we just need to understand that a bit more, and that would be helpful in December if they could explain that. Thank you.
Yes, I mean, actually, I'd hope that they'd covered that last time, but obviously they hadn't quite covered it in enough detail. But
sorry, Chairman, Justin Hackney would like to come in and just...
Okay, but yeah, I think, is he coming in? It really is about this explaining, in effect, the scenarios behind it, Justin. Well, it's like safeguarding is a serious issue, but also it's about making sure that it's fit and the right people get to the right places and the right signposting and connectivity. And also some people do play, I wouldn't say, I suppose lockdown and COVID's caused its own issues, and I've heard some stories that in effect it's like, oh, right, okay, and I suppose that's why there is some of these issues, but further clarity on this is what everybody, I think, could do with.
And I think a rounded discussion as part of the mine and Heather's sort of presentation in December. It'll touch upon the eligibility criteria, if you like, for an inquiry, but also things like Mental Capacity Act, etc. So I think if we focus on maybe the front end of the safeguarding process, that meeting with me and Heather, and we can bring some of the wider board information that we have, and do a good job on it at the December one, if that's okay.
Yes, that's fine. And
Thanks. It is about more than that for me, though. It is about the underachievement, and I would like to review that and bring it back so that we can see where it's going, please. It's not just about the process, it's about the fact that we're not achieving, and we're not achieving by such big numbers. Thank you.
Well, I don't know if achieving's quite the right word. What he's saying is they're trying to get to the bottom of a clearer understanding of actually what should be and what shouldn't be progressed, as I take it. And I think the terminology and the way that we need further clarity on that, which when we can decide whether it's underachieving or not enough. Yep. But I think December's right to bring it back when we've got it on the agenda. So you've got a good theme. Mike?
Yeah, come back on some of the stats that we're given. On page 146, there's a very good graph saying that we've got a high percentage of response. These people that are receiving long-term support, is their review yearly, or what is the timescale on that? Could somebody tell me? Thank you.
Justin or Caroline?
I think it's, am I right in saying, I don't know if Ros is still in the chamber, that it's an annual review?
Everyone's entitled to an annual review, yeah, but people will receive other reviews during the year if they need them. So if circumstances change. So yeah, this particular measure is looking at if people have received a review in the last 12 months. And so yeah.
Thank you for that, but could we have that shown clearer? Because I wasn't quite under that it was a review that had been done within a 12-month period. Thank you.
Thank you. Yeah, I think with a lot of the reviews that happen, some are far more prioritised than others. All depends what everyone's situation is. And yeah, but I know that is always given priority. If you're relatively stable and everything's fine, once a year's fine. If not, like we say, some is pulled forward. Okay, so that report was noted. We've got some actions coming back in December. All okay? All right, thank you. Thank you for that, Justin and Caroline. Okay, so we'll go on to the work programme. Simon.
Thank you, Chairman. If I could ask the committee to focus straight away on page 179. There are 4 items listed for the 20th of October meeting. I won't recount them because they're all listed there, but I would highlight there was discussion on mental health in an earlier item, and there is a Sarah Connery, Chief Executive from the Mental Health Trust, is due to attend together with Jane Marshall, one of her directors, and she's due to attend to provide a presentation on the mental health services and the links between the County Council and the LPFT, as we refer to it. So I would highlight that one. I would also like to mention there was a discussion about volunteer services, and maybe that is something, if the chairman was specifically requesting something on that, I could get in touch with the officers. I don't think it's necessarily going to be picked up. This is what Glenn has advised in the chat. It's not necessarily going to be picked up by the items that are currently listed. So if the chairman or the committee was minded, we could perhaps look to bring an item on volunteer services, clearly maybe not in 2021, but perhaps in 2022, as the work programme is quite full for the remainder of this calendar year. But thank you. I'll take any questions. Thank you.
We're all happy with that. And I think really what we need to do with the voluntary services is take it as a holistic approach to start with for the council and see where we go with it and what happens. Don't you think, Derek? You're in support of that?
Yes, absolutely. We've used and done a lot of work with voluntary and community sector as part of the COVID response, as you know. We're now in a sort of recovery phase, ready to move on to where and how third sector organisations, volunteers, community groups can fit into the emerging integrated care system. So it's probably a good time. We're doing a lot of that work at the moment behind the scenes. So I think, as Simon said, probably towards the beginning of the next financial year or the very end of this one would be a good time to review that. It'll probably go through Health and Wellbeing Board as well.
Excellent. Yeah, I think holistic to start with and get an overview of how it all is, and then we can decide as a committee if we want to drill down or take it further from that point. Andrew.
Yes, thank you. And just on the October agenda, as a new member of the committee, I wonder if it'd be possible to give as much time as possible to the Care Quality Commission, because Derek had so much to say this morning, and I'm not bothered that it took longer than perhaps we expected, because it was all so important. But equally with the Care Quality Commission, their work touches on just about everything we ever talk about. So it would be nice for them to have a good meaty chunk of the meeting. Thank you.
We will give them a good hearing, because Katrina, is it Katrina, or she's coming over. So it's always, when we do have guests come, it's only right that we give them a really good, fair, and also it's right that we get to understand their current travel and direction, which can change over time. Karen?
I just want to echo Andrew's comments, actually. I've really enjoyed the meeting today, and it's been really, really informative. And I don't mind long meetings. As long as we can get loo breaks, I can cope with them. But honestly, I would rather do something thoroughly, because we only come here every few weeks. And, you know, we represent a lot of people. So I'd echo what he said entirely. Thank you.
I will just also add that the adult care specialist services is also very interesting and will be given good time as well, because it is an essential part, and that brings in all the specialist services, daycare, etc., and that's Justin's field. So but no, everything needs to be given its fair time, and like today, it was important that we kept on with the agenda as it was, even though it was large, because actually it is so important to get a basic understanding of some of the preventative measures. My only final thing for December on the mental health is in what has been said today and the prevention, it would be nice to sort of get a preventative early intervention approach on mental health as well, because I think that is, nip it in the bud, is really essential.
Thank you, Councillor Marfleet. Just to add to the work that Justin's been doing on the service provision, we've been working with Sarah on the prevention and the early intervention side. So, subject to there being enough time, we're happy to wrap that all together. It's Lucy's area now, so it'll give Lucy a good thing to get her teeth into for scrutiny for December.
Excellent. We look forward to that. I think we have got very good agendas going forward. So brilliant. Okay, so we'll now go on to item 12 then, exempt information. We have now reached a part of the meeting where we are due to consider. I would like to move the motion to exclude the press and public as set out on the agenda. Can I ask for a seconder? Andrew, thank you. All in favour? Thank you. All in favour. I confirm